The South Texas ADRC, Alzheimer's Disease Research Center, is committed to scientific investigation, but first and foremost are our patients. And we need to be advancing research and finding these cures for helping them. And they need to be at the forefront of our research thoughts as we are investigating. One of your own became one of our own. Professor Fongan is now an NIH-supported investigator, and he began as any of you, and he has become a major player, a major investigator in our institution. As Associate Dean for Research for this institution, we appreciate individuals who are resilient, innovative, and who also have a spirit of collaboration. And we have extended this spirit of collaboration to the group, to the BRAIN group, and to Professor Namchiri. And we hope to take this collaboration to a next level and find cures by Africans for Africans. Thank you.
Thank you so much, Professor Kafasos. So our keynote speaker today is Professor Alfred Konyun Jamshi. So Prof. Jamshi is a distinguished neurologist and neuroscientist, currently a professor at the Faculty of Medicine and Biomedical Science at the University of Yaoundé 1, where he leads the neuroscience lab and oversees multiple residency program. He is also the chief of neurology at the Yaoundé Center Hospital, a Swiss-born certified neurologist and fellow of the Royal College of Physicians. This is in the UK. He has authored more than 180 peer-reviewed publications. Beyond academia, Professor Jamshi is the founder and executive director of Brain Research African Initiative, BRAIN, a global leader in advancing neuroscience research and brain health across Africa. Under his leadership, BRAIN has become an affiliate of the International Brain Initiative and play a pivotal role in the first African high-level summit on brain economy. Professor Jamshi continued to champion brain health, research, and capacity building worldwide. He chaired the scientific committee of the AAIC Neuroscience NEC in Cameroon. Please help me welcome Professor Jamshi.
Thank you very much, Bernard, for that kind introduction. Again, I want to welcome all our friends and my brothers and sisters, I should say, from Spain. Augustin from Spain, now in the US. And I welcome Jose. I welcome my sister Crystal from the USA, my brother Pascal from Central African Republic, and our son, Pascal, our son from Chad, Sakadi, and all the Cameroonians. The reason I welcome them as brothers is that we all, can I have my slides on the? Thank you. I have been asked to talk on building infrastructure for dementia research, care, and policy in Cameroon and French-speaking Africa. I'm told by scientists, it used to be anthropologists, but now geneticists are confirming that we all originated from this great, rich, beautiful, diversified continent, Africa. So everybody on Earth came from Africa. Out of Africa for the world several thousands of years ago. So all of us are brothers and sisters from the same continent. We have been doing some work with our colleagues from the University of Pennsylvania, and we have been looking at indigenous people, the hunter-gatherers of the Central African Congo forest, and others in East and Southern Africa. And one of the things we have been studying is the genetics of the physiology of these individuals. And our last GWISE study demonstrated that the Cameroonian indigenous populations has roots with the Southern African brothers and sisters. And this is many, many years ago in our evolution. We looked at whole genome sequencing of Africans and identified millions and millions of unreported variants, SNPs. We looked at skin color. We looked at genes that affect height, heart development, kidney development, skeletal and muscular development, and we saw that there have been regional adaptations from our genetic makeup to let us be able to live in the different situations of environmental differences that we are. So out of Africa for the world, when this paper was published up in Cell, Professor Tishkov had these comments to make. And I said, from the perspective of an African physician scientist, our work demonstrates the importance of long-term scientific collaborations and highlights the urgent need to include more African populations in genetic studies. If we look at the African population with respect to the rest of the world, we can see from this slide that was prepared for me by the HIMS, it shows that in 1950, people aged above 65 made up only 6% of sub-Saharan African population. And as you can see in South Asia and the rest of the world, it was much more than that. However, this percentage has been growing over the years. And now in 2025, we should be more than 14% of this population aged above 65. And in 2060, this population will be 25%. And in the 22nd century, we shall be above the rest of the world, and this population would be 35%, while still maintaining the young population of Africa, because Africa is generally a young population. So sub-Saharan African population is aging, but at the same time, we are maintaining our youthful population. If we look at the burden of neurological disease in African countries, and if I just take Cameroon for an example, and this is very similar in other African countries, you see that while mental conditions affect the younger generations, stroke and degenerative diseases affect more the elderly population, people above 50. That tells us that we need to take care of brain health across the lifespan. If we look at the burden of disease scaled to GDP, we would see that sub-Saharan Africa has a big loss of its GDP due to brain disease. So brain health is very important. Sometimes some countries lose as much as more than 2% of their GDP because of the conditions that affect the brain. We set up a few years ago the African Dementia Consortium to be able to tackle research in Africa to improve research and use research evidence to improve care and train so that we can change the situation of dementia in the continent. This map shows you the scanty populations, the studies that have been done in Africa. You see incidence prevalence studies that have been done in red, isolated reports on cognitive impairment, isolated reports on cognitive impairment and vascular, cognitive impairment and dementia, and a few places where familial cases of Alzheimer's disease have been studied. These are the statistics for dementia in Africa. General prevalence is about 2 to 20%. Age standardized prevalence is 6.4%, and the incidence varies between 13 and 27 per 1,000 person years. Inside countries, there is a lot of variability because of the diversity of African countries and the rich cultural diversity. A few years ago, my good friend and a team of us looked at the global burden of disease data, and we came out with the triple threat. We looked at stroke, myocardial infarction, and dementia. And we saw from this analysis of the global burden of disease from 1990 to 2021 that these trends are increasing. For the past 10 years, for the past 3 decades, the trends have been increasing in sub-Saharan Africa for these 3 conditions. And this is important to note because of what I'm going to suggest to you at the end of my talk. The burden of dementia is increasing, and more so in the French-speaking parts of Africa, especially in the countries of the Central African sub-region, the CEMAC and CEAC sub-region, as you can see from this figure. This study is under review in the journal Lancet Global Health and hopefully will come out soon. When we looked at the risk factors for these 3 conditions, they are the classical risk factors that we find everywhere. And we have the stress on environmental and occupational risks, behavioral risks, metabolic risks. In all of these 3 conditions, these 3 conditions share common risk factors, and that is important for the control of these conditions. Again, the Institute for Health Metrics and Evaluation prepared this slide for me, and you can see that for countries like Nigeria, Ethiopia, and DRC, by 2050, the statistics, the epidemiology of Alzheimer's disease and other dementias will really spike in these particular countries because of the demographics of the country. It is estimated that 2/3 of the global population will increase in low and middle income countries, and Africa is part of that. And for every 7.2-year increase in age, we have a double increase in the prevalence of dementia. And by 2050, Africa will have the highest global burden of dementia in the whole world. What about policy? We know that WHO has done a lot of work, has done the Global Action Plan on Public Health in Response to Dementia. It's supposed to be concluding this program this year. They have prepared guidelines for countries to use, but unfortunately, only 1/4 of countries worldwide have been able to build national dementia policies or brain health plans that have been effective, with a strategy to support people with dementia and to be able to provide care and to be able to prevent dementia. This is not very good news. The news is even worse when we consider sub-Saharan Africa in particular. The challenges of dementia research, care, and policy are enormous. On this slide, you see on the top left-hand, the median neurological workforce per 1,000 population by WHO. If you look at Europe around the middle, and you see Africa is 0.1, we have the greatest burden currently of these diseases, and we are going to have the greatest burden in the future, but currently we have the weakest workforce to be able to tackle this. This is a real problem. If we look at the median number of adult neurologists per 1,000 population just to the right, Africa is practically 0. And in some countries in Africa, there is no neurologist at all. And then if we look at countries with a dedicated policy for neurological disorders, and this is from the WHO WFN Atlas, well, there we have 25%, but that is not comparable with other regions around the world. If we look at countries with legislation to protect people with neurological disease and dementia and epilepsy in particular, we are still very lacking. So Africa has lots and lots of challenges. A few months ago, one of our brain collaborators, Dr. Kwanlok, led us to look at French-speaking Africa as far as dementia is concerned. And when you compare publications on dementia from French-speaking countries on the left with English-speaking countries on the right, you can see the difference. Most publications in neuroscience, most publications in dementia come from Nigeria, Southern Africa, and Eastern Africa, if we are looking at Sub-Saharan Africa. The CEMAC region, or the CASA region, the French-speaking countries of the Central African sub-region are beginning to pick up, but we still have a long way to go. The challenges of the French-speaking African countries are multiple. We have linguistic challenges, we have sociocultural challenges, and we have many other barriers which we need to tackle together. If we put the map that I showed you before, the heat map that I showed you before about the prevalence, about the triple threat for the past 3 decades of vascular threats to brain health, you will see the correspondence between French-speaking Central African states and the challenge of these disorders. Now, when you have a people who are so diversified genetically, who are so diversified culturally, living in a very diversified environment, and you have a people whose population is aging while still maintaining a youthful population, with the challenge of neurological diseases, and in the past 3 decades, the challenge of heart attack, dementia, and stroke particularly. Most of that in the French-speaking countries of Sub-Saharan Africa. And we are told that by 2050, this is going to spike. And we have the background of a low workforce, no legislation, no action plans. How can you solve such an equation? What is BRAIN's strategy to solve such an equation? We believe in BRAIN that the basis is research. We need a strong research base. We are going to hear later on today on research, all sorts of research, basic research, clinical research, translational research, implementation research, action research. We need data. Because our research is going to inform our training programs. Our research is going to inform our policy, and policy will drive programs. We need procedures, we need to put procedures in place and processes that will all together lead to programs that will prevent, promote, and offer care to people who are suffering from brain disease, and especially Alzheimer's disease and related dementias. A procedure is a set of instructions for completing a single task or activity within a process. A process is a series of tasks and activities that produce a specific outcome. A process has a shorter lifespan, but a program has a longer lifespan. For example, the onchocerciasis control program of Cameroon. That's a program. It is research that determines how we have procedures, processes, and programs that are streamlined to produce data that will inform all these programs. This is our strategy in BRAIN. And what is our research and development model? We all are familiar with the bench to bedside and back to bench and bedside model. That's clinical research and experimental research. But in BRAIN, we have introduced a third leg. We call it the backyard. So we go from bedside to the bench, to the backyard, back to the bedside with our research model. For the bedside, we work at the Central Hospital of Yaoundé, which is the biggest hospital, teaching hospital in Yaoundé. And for our bench, experimental neuroscience research, we have a neuroscience lab, a small neuroscience lab at the Faculty of Medicine and Biomedical Sciences, and we have the students and residents of this faculty here, the choir sang. And for the environment, factors and protective factors, drug use, nutrition, stress, spirituality, plastic pollution, sleep, And there is the concept of the accumulation of risk factors. So I think that it is important for the population that is in this hall now, especially the young population, to know that dementia is not just an issue of elderly people. The things that are affecting you can destroy your brains and accelerate your aging, and you would be at risk of dementia more than it was earlier. The risk accumulation is very important. And if we go back to this slide that I had shown you before, this population is growing. This 18 to 39 years population in sub-Saharan Africa is growing, and we need to focus our prevention strategies on this population. In fact, we need to take it throughout the life course, looking at the baby inside the womb, but for the living now, we have to focus on this young population. It's very important. So that is how we have been modeling our research across lifespan research and development model in Cameroon. And we see that I would now share with you some examples of a research base that has led us to training at the same time. I'll share to you a little story of how we started to study onchocerciasis, related epilepsy. The first measure or the first observation of epilepsy related to onchocerciasis was many years ago in Mexico, where people with onchocerciasis presented with epilepsy. We know that onchocerciasis is a parasitic disease that is transmitted by the black fly of the Simolium genus, and the microfilaria destroy the skin, causing a lot of dermatological lesions, and finally the eyes, and lead to blindness. But little has been known since this observation about how onchocerciasis affects the brain. So does onchocerciasis actually affect the brain? I'll share with you these stories. Statistical observations, meta-analysis have shown that in areas that are endemic for onchocerciasis, epilepsy is also very endemic. And for every 10% increase in onchocerciasis prevalence, you have a 0.4 increase in epilepsy prevalence. This is a review we did to show the relationship between onchocerciasis and epilepsy in African countries. Our studies showed that we have the prevalence of onchocerciasis focus-related epilepsy from 2.5 to 7%, 7.8% in some areas. And the most important study that I will share with you is that we had the opportunity, because of community engagement with our population, where we had studied them 25 years ago and had data on their microfilaria load. 25 years later, we went back to that population and decided to look for people with epilepsy. We discovered that an increase in the microfilaria load in the skin was directly proportional to the risk of developing epilepsy. This was the first longitudinal cohort study to establish this temporal relationship between onchocerciasis in childhood and the risk of developing epilepsy in adulthood. And this study has been repeated in some other places in Cameroon. We have also shown, and others have shown in other parts of the country, that the control of onchocerciasis with ivermectin reduces the prevalence and sometimes the incidence of epilepsy. And this led us to write a paper on the criteria of causality, and what we lack now is the experimental model. If we apply the Bradford-Hill criteria, it suggests that epidemiological evidence that onchocerciasis triggers epilepsy. However, the pathophysiology is not yet known. We suspected that a virus transmitted by the black fly could be the cause, but that it may not be the case. And there are groups now looking at a virus that may be associated with the microfilaria itself. That work is going on. One of our neurologists trained in Cameroon looked at epilepsy-associated neurocognitive disorders. And we discovered that people with epilepsy have neurocognitive disorders which may not be related to the epilepsy itself or to the medication they take for epilepsy. And we went further to demonstrate that These neurocognitive disorders affect the bitemporal and frontal lobes of the brain, and electrophysiological studies confirm this, and we had a nice correlation, the economic factors that are emerging, and consider the risk accumulation. In conclusion, with a diversified population and with partnerships and with government support, political will, we can think of precision medicine. Precision medicine would not be a luxury for Africa. It is not just a dream. Even if it were just a dream, one of the leaders of Africa has said, a winner is a dreamer who never gives up. Mandela never loses. He either wins or he learns. And one great African leader said, the time is always right to do what is right. Now we know the right thing, and this is the right time to do it. And I would like to thank all the collaborators in BRAIN, in the Faculty of Medicine and the universities around the world that have supported us with this work, down our funders, families, patients, and communities who have participated in some of the studies I've shared here, and thank the Cameroon government, and of course, all the funders, Alzheimer's Association, with this strong collaboration between nations. Thank you very much for your kind attention.
Thank you so much, Professor Njamshi, for this powerful presentation. So, Professor Njamshi, I would like to call you again to present the next session. I hope you're not too tired. Excellent. So the next section is focused on the need for an integrated intersectoral approach for dementia risk reduction, research in care in Cameroon, and French-speaking sub-Saharan Africa. I will invite Professor Njamshi to chair this session.
Thank you again, Bernard. I would like to introduce Professor Pierre Ongolo. Professor Pierre Ongolo is Professor of Medical Imaging and Director of Cochrane, Cameroon, and Director of the Center for Best Practices in Health in Yaoundé in Cameroon. Professor Ongolo is a personal friend and brother, and he's going to talk to us as a health strategist on the need for an integrated intersectoral approach for dementia risk reduction and care in Cameroon in particular, and French-speaking Africa in general. Pierre, you have the floor.
Bonjour. Buenos días. Mbambakiri. OK. It's bonjour. J'allais oublier. Thank you to the organizer for inviting me to try to throw out some of the ideas that will actually help us setting the stage for an integrated intersectoral approach for dementia risk reduction, research and care in Francophone Sub-Saharan Africa, and hopefully Cameroon. I should confess that we're well organized around the community with the Ubuntu perspective. We need to consider that disability and vulnerability around dementia will call for a thorough revision of our bioethics and research ethics framework. So dementia in Francophone Sub-Saharan Africa remain full of unknown issues, unresolved, unexpected, but also myth and reality that we need to clarify, as Alfred was trying to point at. My perspective is to say we can't achieve this if we don't consider that our health policy making should be evidence-informed. And the very notion of evidence-informed health policy making has been clearly described. There are key steps to it. We should stop conducting policy based on, eminence or other politician perspective. At some point, at the technical level, we need to consider that evidence is there in our policy. And we should be able, if we apply this principle, to then revise easily our policy. Once the evidence has changed, we can have a discussion and come back and revise some of our strategic options. But if we don't accept this as the very principle to target dementia, we are aiming for failure. So if we have to make informed decision, what is the type of evidence that we need? We need to know about the problems. What are the features of dementia in Africa? What are the driving factors? What works? Making the diagnosis of dementia, that's great, but do we have something to propose to those suffering from dementia? How to put this into practice? Who to involve? And knowing why. Why should we be taking care of this? We can have leading values around equity and human rights to drive us in this endeavor. But do we know how to put it in practice? Do we know how we will use the scarce resources, human, financial, that are around to be efficient and have an influence on reducing the burden of dementia? I also want to re-emphasize that as we are in the room here, Alfred has set the stage. We've seen the center in Texas, how they've been organized. We need to bear in mind that as we are talking about research on dementia, we should have this whole picture in our mind. That research, health research or research for health, have several groups, and we can do this without coming together and knowing, having a clear division of labor, that we can do research. We can have the biomedicals at the sub-individual level, then we have the clinical and behavioral. We can't do this without interacting with one another. At the social level, we need to be clear on what is the appropriate population health research that we need. And most of, above all this, if the system is not organized, if the health services are not organized, we are aiming to influence policy. Do we have the appropriate skills to have this health policy research with all the components in place? These are some of the considerations that we have to bear in mind as we are beginning this long road towards changing something in relation to dementia across Africa. This is another reminder. We have the 4 pillars: epidemiological surveillance, health promotion, disease prevention, rehabilitation, as well as care. And at the heart of this, we need to have health system and resources that are resilient enough to justify the endeavor. I just want to make a comment on this slide. Recently, there was a systematic review that demonstrated that the pool annual risk incidence in Africa is 2%, and that the pool prevalence is 5%, with quite large 95% confidence interval. It means that we still need to do the appropriate research to know what has to be done. Can I convince a minister to invest into dementia care without demonstrating that this is a public health priority issue? There are 2 bullets there. The older age, that's great. We know about it. But if we have a mindset where we consider the elderly as being senior in witchcraft or being the sorcerer, there will be those who are sent out of the village They are discriminated, then marginalized in our society. How do we manage this without bringing in social work? Lastly, there is something that is, for me, a real troublemaker. Low education attainment and poor pre-dementia cognitive functioning at baseline are the best ranked modifiable risk factor for incident dementia. What does that mean from a political stance? If we can't send children to school, if we can't send young girls to school, if we are mostly promoting alcohol drinking, harmful drinking, then we are paying our first-class ticket to the dementia epidemics across Africa. If we are not making everything to train the younger generation, we are buying our first-class ticket to the epidemics of dementia across Africa. What does that mean? To conclude, we need to have clear health need assessment mechanism in place so that we can advocate for people to do what they have to do. We have a big issue on ethics and regulatory frameworks around dementia. In society where we have polygamous families, as a radiologist, I had a big challenge. One of the sons brought the father. When he realized that he was diagnosed with Alzheimer, he went and tried to change the testimony. And then I had to attend a family meeting with the question, when the dad came, did you give the diagnosis to the son? Yes, but I didn't know. So we need to be clear that there are regulatory framework to protect those who are suffering from dementia. Otherwise, everything that we'll be doing won't be ethical. We need to reorient our health services, and we can't do this without the appropriate evidence. If we want to mobilize our community, we can't do this with evidence. We can't do this with the evidence that will help us convincing traditional leaders, convincing funders, informing politicians that this is actually people who can vote. Somebody who is suffering from dementia, is it a voter or not? How do we invest on enhanced health governance where everything is not just driven by money, that we have in mind that the value of every public health system are around equity, quality of care, and the human rights perspective? And finally, what do we mean by universal health coverage? We should be inclusive, and we should be able to accommodate those seniors who will be suffering from cognitive impairments. Thank you.
We thank Professor Ngolo, who is an imaging specialist. And from that bias, he has x-rayed the health system because he also has an expertise as a health analyst, health system analyst. Thank you very much for bringing us and challenging us with those thoughts. Yes, a lot of work needs to be done because of our cultural complexities and because of some of the challenges that we have been discussing since morning. But having people like you and the rest of us in the room, and having these young people in the room, I think that some of them are here and they would be able to pick up ideas for their MD thesis, for their DPharm thesis, and for their residency dissertations. to be able to provide some of the evidence that we need. And we would need not only people in medical school. I know that here in this hall we have students from Polytechnic, our National School of Engineering.
Le professeur Nga nous l'a dit tout à l'heure, l'hypertension artérielle, le diabète, l'obésité et le faible niveau d'éducation sont des facteurs de risque majeurs de démence. Ainsi, il est centré sur les changements de mode de vie, notamment l'alimentation, l'activité physique et la stimulation cognitive. Deuxièmement, nous devons renforcer les systèmes de santé pour un diagnostic et un traitement précoce à travers la formation des professionnels de santé. Ainsi, le renforcement des capacités des médecins de premier secours, des infirmières, mais aussi des agents de santé communautaire est essentiel. Nous devons aussi intégrer les soins de démence dans les services de santé primaire. Étant donné la rareté des neurologues, des psychiatres, les agents de santé de première ligne devraient être équipés pour un diagnostic et prise en charge de la démence à un stade précoce. Nous devons investir dans la recherche. Nous l'avons dit, le professeur Jamshi l'a dit. Les études épidémiologiques locales, telles que c'est fait dans certains pays de la sous-région, apporteraient, n'est-ce pas, des informations sur la prévalence, l'incidence, ainsi que les facteurs de risque dans le contexte africain. Nous pouvons aussi parler des essais cliniques et des innovations à encourager dans les collaborations avec des institutions mondiales pour la recherche sur la démence afin d'améliorer les options de traitement. Nous devons élaborer des politiques et engagements du gouvernement à travers les plans nationaux de lutte contre la démence. Les gouvernements devraient élaborer des politiques pour soutenir les soins, la recherche et le soutien aux soins en matière de démence, et aussi favoriser les allocations de ressources à travers l'investissement accru dans les services liés à la démence, y compris les cliniques de mémoire. Nous pouvons ici saluer l'initiative déjà réalisée par notre cher maître, le professeur Jamshi, à travers la clinique ressources et mémoire telle qu'il a engagé dans notre pays. Alors, nous devons aussi soutenir les soins et les services sociaux à travers la formation et les aides financières pour les soignants. La plupart des soins, nous l'avons dit tantôt, liés à la démence, sont dispensés par les familles, ce qui entraîne souvent des difficultés économiques. Les gouvernements et les ONG devraient proposer des programmes de formation et d'aide financière. Aussi, on devrait créer un réseau de soutien communautaire à travers la création de communautés favorables à la démence pour contribuer à améliorer la qualité de vie des patients et de leurs familles. En conclusion, la démence est un défi de santé publique émergent au Cameroun et en Afrique subsaharienne francophone qui nécessite une attention urgente. Une approche intersectorielle impliquant les initiatives de santé publique, le renforcement intersectoriel, la recherche, l'élaboration de politiques et le soutien social peut améliorer la prévention, le diagnostic précoce ainsi que les soins de la démence. En favorisant la collaboration entre les gouvernements, les prestataires de soins de santé, les chercheurs et la société civile, le Cameroun, aussi bien que la région francophone subsaharienne, peut développer un cadre durable pour faire face à la crise croissante.
Thank you very much, Dr. Yemjo. Many years ago, we didn't have a geriatrician in the country. And I'm glad to introduce to you Dr. Josiane Ebode-Nsama, who is a specialist in geriatric medicine, senior lecturer in our faculty, president of the Cameroon Association of Geriatricians, president of the Brain Community Engagement Advisory Board for our READS ADSP project and other projects. Josiane, you have the floor.
Thank you, Professor, for giving me the floor. Thank you once more to the steering committee of this conference for having me this morning. I'm delighted to share with you our perspective on the risk reduction, care, and research on dementia in Cameroon. Our disclosure. I will start by saying that while the Cameroonian health system is still struggling with the heavy burden of infections, it also faces the rising trend of non-communicable diseases, and this is due in part to the aging of our population. It is true that some chronic conditions like cardiovascular diseases, cancer, receive more attention as emerging public health problems from our including frailty, and their role has been pointed out in the poor outcome of these patients. It is also important to notice that dementia is one of the leading causes of dependency in older people, even in our setting. And from the geriatric perspective, we have identified some few challenges. Firstly, early identification of older adults at increased risk of dementia remains very difficult, owing to numerous factors, including beliefs. People still believe that dementia is part of normal aging. We also face the lack of trained health caregivers. It is true that rely solely on clinical manifestations of dementia to identify older adults with declining cognition may result in missed opportunities to early interventions to delay transition to frailty and dependency. The second challenge is probably the recognition of dementia as a major public health problem. It has a serious impact on the whole society, as well as impacting on organization of patient care in our setting where geriatric care are still scarce. And unfortunately, the support systems for patients and their family caregivers do not provide enough solution, taking into account our local resources. As perspective, we think that one of the approach will be probably a proactive screening that could help us to foster early interventions to maintain intrinsic capacity in order to delay complications associated with dementia. The WHO has provided recently tools and guidance to community health workers to develop community-based integrated care approaches to improve, maintain, and in a certain point, slow the decline in the 6 core domains of that intrinsic capacity, including cognition. And this is known as the integrated care to other people approach. It can be a real opportunity for Cameroon and other countries of the sub-Saharan Africa, as it will help to identify early those in the community at risk of cognitive decline. I will end my presentation by saying that as more detailed and reliable studies emerge, it is increasingly apparent that dementia is associated with a high complication burden in our setting, which will be probably difficult to manage and to prevent. So we humbly think that programs to promote prevention in the community are not only relevant, but they are also necessary to deliver appropriate interventions. And maybe future improvements will depend also on practical and sustainable support coupled with a local acceptance of dementia as a major threat by all the stakeholders. Thank you.
Thank you very much, Dr. Ebode. I remember when Dr. Temgwa was coming from Côte d'Ivoire to our neurology service for his clinical practice as a neurology resident in Côte d'Ivoire before we developed our own residency program. Many years ago, he came back as a full neurology consultant, and he subspecialized in neurorehabilitation and has actually created a practice of neurorehabilitation in Yaoundé. I'm very pleased to introduce to you Dr. Michael Temgwa, who will bring to you on this same important topic the point of view of a neurorehabilitation specialist. Michael, you have the floor.
Thank you, dear Master. Dear international guests, dear masters, dear colleagues, and dear participants, it's my honor to be here in this great conference to talk about neurorehabilitation and especially cognitive neurorehabilitation. So I really want to thank Professor Njamshi and all the brain team for all the effort for the promotion of cognitive neurorehabilitation, and also to put light on dementia in Cameroon and in Africa. So my presentation will be in French, and all my slides will be in English. Okay. Donc, lorsqu'on parle de neuroréhabilitation, et en particulier de neuroréhabilitation en ce qui concerne les troubles cognitifs, eh bien, il y a une triptyque qui est quasiment systématique chez tous ceux qui pratiquent en rééducation. Donc, il y a d'abord le terme rééducation, c'est-à-dire récupération des fonctions cognitives perdues, lorsque cela est possible. Ensuite, il y a une autre triptyque qui est donc la réadaptation, c'est-à-dire l'utilisation des fonctions cognitives récupérées ou alors restantes dans les activités de la vie quotidienne. Et enfin, la réinsertion, c'est-à-dire la réintroduction de la personne donc, qui présente des troubles cognitifs dans la société, dans son travail, ainsi que dans sa famille. Donc, ceci dit, lorsqu'on évoque cette triptyque-là, il nous semble évident que la prise en charge en neuroréhabilitation implique de façon claire la participation de différents types de personnels de santé. Donc, les neurologues, bien entendu, les gériatres, les infirmiers, les physiothérapeutes, et ainsi que tous les personnels de santé, notamment les infirmiers, qui peuvent participer donc à cette prise en charge-là. Mais de façon évidente, étant donné qu'on évoque également le concept de réinsertion, il va de soi que nous sommes également obligés d'intégrer non seulement la population générale, mais également les familles. Parce que, comme mes prédécesseurs l'ont dit, si on ne tient pas compte de la réinsertion et de l'implication des familles, eh bien notre travail sera en quelque sorte un peu vain. Donc la rééducation en ce qui concerne les pathologies cognitives, donc forcément intègre cette approche d'équipe-là entre les professionnels de santé, mais également entre les familles et la communauté. Alors, nous avons expérimenté cela en 2024, donc dans le cadre de l'Association camerounaise de neuroréhabilitation, où nous avons travaillé dans le district de santé de Soa, qui est un district de santé semi-rural, donc qui se trouve non loin de Yaoundé. Et nous avions donc discuté avec donc les responsables de ce district de santé-là, dans le but justement d'essayer de mettre sur pied, de les aider donc à prendre en charge en fait leurs patients qui potentiellement présenteraient des troubles cognitifs. Donc, en termes d'objectifs, donc nous avions 3 grands objectifs déjà. De faire en sorte d'organiser des campagnes de sensibilisation au sein du district, donc en ce qui concerne donc les facteurs de risque et surtout les signes précoces. Ensuite, former les personnels de santé autant que cela a été possible donc à l'utilisation des tests très simples donc pour la détection précoce et aussi pour la prise en charge donc des patients atteints de troubles cognitifs. Et enfin, donc essayer de mettre sur pied cette forme d'équipe-là donc pour assurer donc la continuité des soins. Alors, à l'époque, nous avions utilisé une méthodologie assez simple. Nous avons, dans un premier temps, organisé une conférence où nous avions invité donc tous les professionnels de santé du district de santé, donc sous la supervision du médecin-chef du district. Nous avons, par la suite, organisé 2 sessions de formation, 2 séminaires de formation, donc pour les personnels de santé, où tout type de personnel de santé était représenté, c'est-à-dire des infirmiers, d'ailleurs, qui étaient les plus nombreux, les aides-soignants, les physiothérapeutes, mais aussi les médecins, notamment les médecins généralistes. Dans un troisième temps, nous avons organisé une campagne de sensibilisation de porte à porte, donc dans le but précisément d'apporter l'information donc à la communauté et aux populations, donc du fait que effectivement il y avait non seulement une campagne de santé qui allait être organisée, mais surtout qu'il était important de les sensibiliser eux-mêmes à ce que c'est que les troubles cognitifs. Et enfin donc nous avons organisé au sein du district, en particulier à l'hôpital de district, donc une campagne de dépistage des troubles cognitifs avec la participation donc des professionnels de santé. Alors, qu'est-ce que nous avions obtenu comme résultat? La première chose, c'est que déjà les personnels de santé avaient été très intéressés donc, par ce programme-là. Donc nous avons pu au total former 69 professionnels de santé. Donc comme participants, comme formateurs, on avait donc 2 neurologues et 2 psychologues. Donc il y a 69 personnels de santé qui avaient été formés. Ce que nous avons constaté, c'était que pour la plupart des cas, les personnels de santé n'étaient pas informés de ce que c'était que les troubles cognitifs. Très souvent, les mêmes remarques qu'on fait dans la population générale étaient valables également pour les professionnels de santé. Voilà. La seconde chose, c'est que, en ce qui concerne donc notre campagne de sensibilisation de porte à porte, nous avons pu sensibiliser 121 ménages donc à ce que c'est que les troubles cognitifs et surtout dans la lutte contre les perceptions sociales erronées. Parce que comme l'a dit mon prédécesseur et cher maître, le docteur Yebjo, très souvent, les troubles cognitifs et la démence sont associés à la sorcellerie et à toutes sortes de pratiques mystiques. Et c'est également ce que nous avons retrouvé au sein du district de santé de Soa. Et lors de la campagne de sensibilisation, nous avons pu sensibiliser nous avons pu faire des dépistages pour 37 patients. Il faut noter que les dépistages étaient réalisés par les personnels de santé qui avaient été formés en l'espace de 2 semaines. Et ce que nous avons obtenu comme résultat, je pense qu'il nous a énormément encouragé, c'est que parmi les personnels de santé, pratiquement les 3/4 étaient capables justement de mener à bien les tests de dépistage, donc qui avaient été appris environ 2 semaines plus tôt. Alors, ceci nous a aidé justement à tirer quelques conclusions justement qui peuvent nous aider lorsqu'on veut évoquer justement la prise en charge, en particulier en neuroréhabilitation, des personnes donc présentant des troubles cognitifs et également des personnes qui présentent des démences. Donc, il y a des préalables. La première des choses, évidemment, c'est d'améliorer effectivement la prise en charge. C'est la base même donc de la prise en charge en rééducation cognitive. La seconde chose, évidemment, c'est d'améliorer justement la sensibilisation, non seulement des populations générales, donc pour lutter contre les mauvaises, mais également les personnels de santé. Parce que si les personnels de santé eux-mêmes ne sont pas sensibilisés à ce que c'est que les troubles cognitifs, à ce que c'est que les démences, si eux-mêmes ont tendance à penser qu'il s'agit, comme l'a dit mon prédécesseur, de la folie, c'est que nous savons très bien que eux qui sont chargés justement d'éduquer la population générale, eh bien, ne pourront pas donc atteindre cet objectif-là. La troisième chose, le troisième pilier pour nous, si on veut parler justement de neuroréhabilitation, en particulier de formation d'équipe de neuroréhabilitation, c'est évidemment la formation. Il est indispensable que nous ayons des formations et surtout des formations adaptées pour nos personnels de santé. Et ça c'est forcément en relation également avec donc, le quatrième point que nous avons évoqué, donc c'est évidemment la collection des données. Parce que durant toutes ces campagnes, nous avons utilisé par exemple des tests de dépistage qui n'étaient pas forcément normés avec nos populations. Nous les avons quand même utilisés puisque ce sont les outils que nous avions à disposition. Mais cela montre bien que si nous voulons être réellement efficaces, il faut absolument que nous puissions avoir des études locales, donc qui puissent nous apporter des données afin que nous puissions adapter également nos prises en charge en rééducation cognitive donc aux patients que nous avons couramment dans la communauté et au Cameroun. So, thank you for your kind attention.
Thank you very much, Dr. Temgwa. I would just like, as we transit into the panel session, to invite the speakers, Professor Bisek to chair, Professor Ngolo, and all the speakers, and including our friends, Professor Mbeloso, Dr. C, to the podium. For the panel discussion.
As they are coming up, I'll also invite our rapporteurs, Dr. Leonard Ngaka, Dr. Chokote, and Dr. Kongyu Kamsi to come to the front, please.
Listen to him. As the panelists take their seats, I would like to give the honor to our brothers from CAR and Chad. We have listened to several people present to us on the need for an integrated intersectoral approach for dementia risk reduction, research, care, and policy in Cameroon and Sub-Saharan Africa. I would like to ask Dr. Sakadi to give us the background in about maximum of 3 minutes, the background in and the insights that he has to share with us in this approach that we are building. Dr. Sakadi, please.
Thank you very much, Professor Alfred, for the invitation, and thank you for giving me the floor. As you know, Chad is the neighbor of Cameroon, so maybe we have the same problem. Maybe in Chad we have more problem than here. So globally, you can say that Chadians are more than 17 million people, and most of them are young. And the healthcare system is not well for take care of people. About dementia, we don't have much study published on it, and we think that with this collaboration, we will do much about that. Anyway, I think so many people has dementia, and the problem is even we don't have much research, but we need also the sensitizations, because so many population, when they come to the consultation, if you ask about the loss of memory, they will say that it's normal, doesn't matter, because he's old, that's why he's losing. So it's important for us to do much sensitizations. For the study, we think that it's good to go to rural and for the sensitization and also for study. And I think that we are ready, our team are ready to work together to take much people, to take care of them, and to ameliorate this care of dementia. Maybe I will add something later, but this is what I can say now.
Merci beaucoup.
Je voudrais d'abord vous remercier, le professeur Njamsi, pour nous avoir associés à cette réflexion qui va apporter certainement beaucoup de changements dans notre pratique. Effectivement, je suis de la République centrafricaine où il y a environ 6 500 000 habitants, dont la plupart est concentrée surtout dans les grandes villes, en particulier environ 2 millions à Bangui. Et le système de santé a été ébranlé par tout ce que vous savez qui a secoué le pays, et on est en train de se remettre donc progressivement. Comme vous l'avez dit, nous avons conduit beaucoup d'études sur les démences depuis les années 2008, où nous avons coordonné les activités de recherche sur les démences en Afrique centrale, en particulier en République centrafricaine et au Congo. Et donc, ces études que nous avons faites en milieu urbain et en milieu rural nous avaient déjà indiqué que le taux de prévalence des démences était de l'ordre de 8,1% en République centrafricaine et de 6,7% en République du Congo. Et donc, on a retrouvé les mêmes facteurs de risque que vous avez, qui sont sortis donc dans ces différentes présentations. Malheureusement, ces études n'ont pas poursuivi et c'est avec beaucoup de plaisir que nous allons relancer donc ces différentes activités. Néanmoins, des études hospitalières, on n'en a pas fait beaucoup. C'est surtout dans le cadre donc du neuro-VIH où nous avons fait une étude que nous avons publiée sur les troubles neurocognitifs chez les personnes vivant avec le VIH. Et donc, ce serait avec plaisir, c'est surtout avec plaisir que nous allons associer nos efforts pour pouvoir donc mener cette étude multicentrique afin de pouvoir donc sortir donc cette pathologie de l'ombre et mettre en place, et pourquoi pas mettre en place un programme de lutte contre donc, cette maladie. C'est avec beaucoup de plaisir que je participe donc à cette activité. Je vous remercie.
Merci beaucoup, cher frère. Est-ce que vous pensez que avec ce projet que nous sommes en train de mettre en place, le BUILD FSA, Building Unique Infrastructure for Large-Scale Dementia Research in French-Speaking Africa, est-ce que vous pensez qu'avec ça, on peut arriver à convaincre nos leaders politiques pour mettre en place des programmes de lutte contre la démence en particulier et la santé du cerveau tout court en République centrafricaine et au Tchad?
Bien, merci. Je pense qu'il faut être optimiste. Il faut être optimiste. Nous entamons une activité que nous souhaitons que ça puisse réussir et nous n'avons pas droit à l'erreur. Et donc, il est de notre ressort de pouvoir convaincre donc, nos dirigeants et surtout d'expliquer que sans la santé du cerveau, tout le reste du corps va avoir donc des difficultés pour son bon fonctionnement et ça va jouer également, on le disait tout à l'heure, les dépenses en ce qui concerne donc la démence sont beaucoup plus supportées par la famille et c'est la famille qui est le moteur du développement. Et donc, s'il y a des programmes qui sont mis en place pour pouvoir donc réduire l'impact donc financier au sein de la famille, ça permettrait donc à la famille de s'occuper donc de pas beaucoup à ce challenge que nous sommes en train de mettre en place. Et donc, il est de notre devoir de pouvoir réussir. Je vous remercie.
Je pose la même question au Dr Sakadi. Qu'en est-il de cette possibilité au Tchad et qu'est-ce qu'on peut faire ensemble?
Merci beaucoup pour la question. En fait, s'agissant de gouvernement à des autorités, pour la petite expérience que j'ai, je crois qu'à chaque fois quand il y a des belles idées, ils agissent. Peut-être que la manière peut être améliorée, mais je crois qu'ils sont attentifs à tout ce qui peut être bien pour la population. Et donc, je crois que quand on fait ce genre d'études avec des données claires, je crois que c'est très facile de les convaincre et de pouvoir faire un programme national sur les pathologies neurologiques. Aujourd'hui, nous n'avons pas, au ministère de la Santé, nous n'avons pas assez de programmes sur les pathologies non infectieuses. Et donc, par exemple, nous avons un programme sur la santé mentale c'est pas très bien développé parce que peut-être celui qui gère n'a pas tous les atouts. Après, il y a aussi le programme sur les maladies non transmissibles en général. Il y a un programme sur le paludisme et c'est pas très développé, mais quand même il y a ce genre de programme. Aujourd'hui, si nous partons avec quelques données pour leur parler de cela, j'estime que c'est très possible de pouvoir mettre sur place un programme de lutte contre les pathologies neurologiques. Et surtout avec le programme AEGAP, international, intersectorial global health.
Intersectorial Global Action Plan for
Voilà.
Epilepsy and other neurological diseases, yeah.
Avec ça, j'estime que si on vient vers eux, ils peuvent être vraiment très attentifs.
Merci beaucoup, c'est très intéressant parce que vous évoquez le problème de santé mentale. C'est aussi un endroit où il doit avoir l'intégration parce que nous savons tous, nous avons évoqué dans certains papiers que le programme de santé mentale est stigmatisant et limité dans son scope. Et puis, le concept de brain health est plus acceptable pour les populations. Et si nous pouvons convaincre les leaders politiques et les autorités et même les financiers, ça peut être un bénéfice pour nous tous. C'est très intéressant. We are going to give a room for 1 or 2 questions from the audience before we get back to the panel to draw a conclusion on this important discussion. We don't want you to be left out. If you have any burning question, just raise your hand, 1 or 2, and then a microphone will be brought to you. Raise the hand first, and then I'll accept. Any questions? Est-ce qu'il y a des questions? Yes, there's a hand. A second hand. That's perfect. Right behind you. Yeah. Just say your name and then ask your question, please.
Merci, cher maître, de me donner la parole pour poser la question parmi vous. Je réponds au nom de Yakire Teyawe. Je suis un interne de la faculté de médecine et des sciences biomédicales de Yaoundé. Je voudrais demander quelles seront les stratégies et les méthodes que nous pouvons mettre en place pour pouvoir permettre de véhiculer les informations des centrales à la périphérie pour assurer la couverture sanitaire concernant la santé mentale. Je vous remercie.
Merci beaucoup pour votre question. On va prendre la deuxième. Est-ce qu'il y en a d'autres?
Thank you very much, dear masters and panelists, for the opportunity. Thank you very much for the presentation. My one burning question is that of for Dr. Temgwa Michael. In terms of brain rehabilitation, especially prevention of dementia risk, what is more recommended? A patient, an aging patient who is gradually deteriorating in brain population, is it recommended to help the patient do his things or to permit the patient help himself or do the things himself so as to keep the brain working? Which one is more, or which one has been proven to be more effective? Thank you.
Okay, we also thank you for that question. We have a third question. We'd like to take all of them. You either ask your question to a specific speaker, or if it's a general question, go ahead, please. Say your name, and then go ahead.
Okay, my name is Foba Midrenbo. Okay, talking about dementia, please, you said it mostly affects the French the French part of Africa. Please, I wish to know, is there anything they are doing or are not doing that is mostly affecting them? Thank you.
Thank you. Okay, I think we can try to answer that series. First, the first question was on what do we do to take information to the people who are suffering from mental problems. And then the second question was specific to Dr. Temgwa. And then the third question is on the burden of dementia in the French-speaking part of Africa. I'd like to know if Prof. Ongolo would like to take the first one.
Okay, thank you very much. I will start by a small comment. I'm just wondering if we were to have a survey in the room, how do they name dementia in your village? An elderly with cognitive impairment, how will you name him or her in your village? It starts like this. If culturally we don't know what is going on, then we'll still have a proxy of the burden of cognitive impairment. Last month we have a café éthique on dementia, and one of the recommendations was to stop talking about dementia and talk about cognitive impairment. It was surprising for those with biomedical background, but it seemed this is what was most convenient for those without the biomedical background, that talking about dementia have some elements of discrimination, of marginalization, while talking about cognitive impairment will probably reduce, because the wording from our cultural perspective tend to turn it to madness. And because mad people are considered to be dangerous, they will be marginalized. And in some of the village, they will be called witchcraft professional. And again, they will be marginalized. It start there. But now, why is it that there are problems in relation to Francophone Africa? I'm not sure that the research is not done. The research is there. But those who are conducting research in French probably are not seen when you are looking for research. And because we have few neurologists across Francophone Africa, we don't have enough human resources to do the research and then make people know that there are troubles of biscuit. And so some of this kind of letting go people with alcohol consumption might explain some of the challenges, as wine or alcohol is considered to be part of the freedom. This is just a joke, but for you, the younger generation, this is probably your fight. And I also wanted to add another element around the urbanization. In most Francophone African countries, when you observe the urban setting, there's a lot of laissez-faire, very few room for infrastructure, for outdoor activities. And again, with urbanization and sedentarity, lack of physical activities, people will tend to be obese and without outdoor activities that reduce community activities for the elderly. Just an example, how many kilometers of sidewalk do we have in Yaoundé so that elderly can come out and walk just doing this exercise, but it's just challenging. And lastly, for the younger generation, screen addiction, addiction to phone, addiction to online gaming is also appearing as one of the factors that will contribute to sedentarity, alcohol consumption, cannabis consumption, and will alter cognition in the younger generation. This is what I wanted to add. But at the end, to provide a suggestion, I was insisting on how do we mobilize the communities. First, we need to speak their language. And how do we speak their language if we don't know if this has been there before? If we are bringing MRI, and then after me as a radiologist saying, okay, there is an atrophy of, we say, Shelton's 4 of the hippocampal, and we say this guy has dementia. How many people in Cameroon can afford a brain MRI? Very few. So how do we cognitive impairment in Tokombere, in Salapumbe, in Gidigis, or in Ezeka? Who should be able to do the diagnosis? Do we admit this disease as being our disease, or is something that has been imported? This is the kind of question that we concept and bring them down to earth, down to the real world. Mental health is probably an interesting perspective. What about just using the well-being and having a composite indicators on what is the well-being of people? Because again, even the mental health continue to say he has a mental disorder. And again, somehow it will be it will create marginalization, and it can discriminate. A lot of people in with social science background will tend to prefer the well-being wording, but we need equally research on the discourse around mental health, dementia, well-being, so that we can reach to those in remote area. Just guess one of the best joke in our campuses when somebody is having some deviant behavior. What is the joke? Sa tête jette l'air. Okay, and it's like, so there are some of those traditions that we need to be clear, but we need science, we need people to work on psychology, to work on anthropology, so that we don't create institutional discrimination. This is what I want to add on issue on mental health. But now in terms of integrating, the discussion should start within the technical field, bringing those who will help us getting to the grassroots, not having this discourse in Yaoundé, and then when you reach Ekondotiti, people just don't understand what you are talking about. Thank you.
Thank you very much on that. In fact, the discussion on the dichotomy between mental health and brain health is being handled, as you mentioned, at very high levels. During the World Economic Forum that just took place last month in Davos in Switzerland, the issue of funding brain health, which includes mental health, was raised. And bankers and investors understand more, and they seem to stick more with the concept of brain health, which is less stigmatizing. And there was a newspaper caption that brain health is top priority in Forbes. You know, Forbes is an economic magazine. So I think that that discussion is ongoing. And during the preparatory meeting for the G7 summit that will hold in June, the preparatory meeting took place in Canada last month. The idea, the concept of brain health, which encompasses mental health, was accepted by the working group that was there. And I think that in terms of policy, for us in Africa, we need to have that technical discussion at our level so that later on in the year, when the G20 summit will be holding in South Africa, we should be able to have a common language, because one of the big issues in Africa, as we have discussed since morning, is health research financing, healthcare financing. And if we need to bring in investors and philanthropy, we need to use language that is attractive to them and not discriminatory. And the concept of brain health is gaining some traction. Just wanted to know if there's a last question before I come back to the panel for last word and conclusion. Yes, I can see 4 hands up. Give the mics to the 4 people, and that will be the last set of questions. Dr. Kwanlak in front. Just keep your hand until you have the mic, please. Okay. One to Dr. Kwanlak. There are several mics. Just say your name and say who you are, a student, resident, or a physician, and then or whatever your specialty is. We'll start from you. Just straight to the question, please.
Bonjour, mon nom c'est Fopa Franck et je viens de l'École nationale supérieure polytechnique de Yaoundé.
Very good.
Et si je fais cette précision, c'est pour savoir, en tant que futur chercheur, je veux savoir qu'est-ce que vous attendez de nous pour pouvoir, qu'est-ce que vous voulez que nous puissions apporter pour pouvoir aider à lutter contre la maladie d'Alzheimer. Merci.
Merci pour votre question. On prend de la série.
Okay, thank you for giving me the floor. I'm Dr. Kwanlak Cyril. I'm a neurologist at the Buea Regional Hospital and a lecturer at the Faculty of Health Sciences, University of Buea. I have 2 questions to 2 masters. One to Professor Ongolo and one to Professor Zonkani. My question, number 1, to Professor Ongolo is this. During your presentation, I was caught by the ethical dilemma that we face when managing these patients with dementia. And we all know that this lives from the time of diagnosis to the moment we are taking care of these patients, and even goes to the moment of research, as you said. In these discussions, how do we integrate the legal framework? How do we make sure that the legislature also is included in the decision-making process so that the laws that can protect these people living with dementia? My second question to Professor Zonkani is, we have had several programs in our nation, and the programs that align with neurological disorders like epilepsy program, the IGAP, which is still to be implemented, most of the time we face a lot of challenges. I am from the peripheral level at the operational level. And most of the time we have high-level discussions like this. And to get impact at the peripheral level is a bit challenging. I would like to know from you, how can it be more easier for us at the peripheral level to feel the impact of all these policies? Thank you, Professor.
Last 2 questions.
My name is Monique Chiapi. I'm from UK, Manchester. I'm a senior radiographer in one of the hospitals. I've got I had 2 questions, but I think the professor has answered the first one. The second one is to do with access to imaging technology, such as MRI and CT scans. These are those imaging are very important and is crucial role in the early and accurate diagnosis of dementia. What steps can be taken to improve the availability and affordability of these diagnostic tools, especially in underserved communities? Thank you.
The last question.
Okay, thank you for giving me the floor. I am Professor GJ, lecturer at the Department of Physics at the University of Yaoundé 1. So I have a request. So when listening to the presentation this morning, many subjects are related to prevention and rehabilitation, and a little about the treatment. I want to know if in the future, maybe in the future, the Alzheimer Association can include some subject related to the treatment. Then we can talk about some clinical trial, because in our Department of Physics, we conduct some research in this way. So just is a request, not a question. Thank you.
Thank you very much. I would like the panel to take the questions. I know that there's a hanging question for Dr. Temwa, and then the panel will take the rest of the questions.
Ok, très bien. Merci, cher maître, de me passer la parole. Alors, en ce qui concerne la question, justement, concernant qu'est-ce qu'il faut faire, justement, des patients qui présentent des troubles cognitifs ou des démences. Alors, moi, je vais parler de notre pratique dans le monde. Alors, comme je l'ai dit tout à l'heure, quand on parle de neuroréhabilitation, il y a une triptyque qu'on aime souvent employer parce qu'elle est plus simple pour nous. C'est-à-dire rééducation, quand c'est possible de récupérer des fonctions, d'accord ? On essaie de mettre en place un certain nombre de choses. La réadaptation, donc, c'est-à-dire les fonctions récupérées, on essaye de faire en sorte que la personne puisse les utiliser dans les activités de la vie quotidienne. Et le troisième pilier, donc, c'est la réinsertion, donc le fait de réintroduire la personne dans la communauté. Donc, il y a des patients pour lesquels on fait juste de la réinsertion à cause de la sévérité, du fait qu'il n'y a plus d'autonomie. Et puis, il y a d'autres chez lesquels on peut aller, on peut intégrer les trois piliers. Et la chose essentielle, justement, là-dedans, c'est l'autonomie de la personne. Est-ce que la personne est encore autonome? Est-ce qu'elle est capable de se prendre en charge? Est-ce qu'elle est capable par elle-même, justement, de faire des choses, de mener des activités? Voilà. Et donc, quand on a des patients, par exemple, qui ont des troubles, par exemple, des troubles de la mémoire isolés, associés peut-être à d'autres troubles, et que la personne est encore capable de se prendre en charge, en général, c'est chez ces patients-là qu'on insiste beaucoup sur la rééducation, donc sur le travail des différentes fonctions cognitives affectées. Et ce qui se passe souvent, c'est que donc on va voir par exemple le neuropsychologue ou l'orthophoniste ou celui qui a été formé à cela, donc pour qu'il mette en place un certain nombre de stratégies qui peuvent consister en des séances de rééducation dans le cabinet ou alors en des choses que la personne fera à domicile. Et par contre, quand la personne n'est plus autonome, en général, ce qu'on fait, c'est qu'on met beaucoup plus on est dans un travail d'accompagnement. D'accord, on fait en sorte que la personne puisse s'occuper d'elle et surtout puisse avoir une insertion la plus acceptable possible. Et ce qu'on voit très souvent, comme vous le savez certainement, c'est que c'est des pathologies quand même qui isolent socialement. D'accord? Donc, tant que la personne est capable, quel que soit le stade de sa pathologie, tant qu'elle est capable de faire des choses sur le plan intellectuel, sur le plan social, si elle veut participer à ces réunions de famille, à ces réunions d'association, etc., eh bien, nous, on encourage en général donc à faire en sorte que la personne puisse donc mener ces différents types d'activités. Là, naturellement, il y a des personnes qui ont besoin de plus d'assistance que d'autres. Parce que quand même, ce qui est important aussi, c'est la sécurité de la personne. Il nous est souvent arrivé, je suis persuadé également que mes collègues rencontrent cela assez souvent, de voir des personnes qui viennent en cabinet, en voiture, en véhicule, qui semblent être autonomes, mais bizarrement, lorsqu'on fait les tests, on se rend compte que ces personnes-là ont des troubles cognitifs extrêmement sévères et qu'en réalité, elles ne sont même plus autonomes. Voilà. Donc, vraiment, tout part de l'évaluation et de voir si la personne est encore autonome ou pas. Voilà, merci.
Professor, I can add something. What we have usually see in our clinical practice, we see people with cognitive impairment. Usually, the caregiver want to help them for all activity. So what we usually advise them is to leave the patient, try by himself, then when it's not succeed, then they can help him. That is the first thing. Another thing is that when they reach the house, they just put the patient in front of TV all the day because there's no one taking care of him. People that to school and even the father to the work. So he stay all the day in front of TV. So such practice we usually ask caregiver and the family to avoid them. So give opportunity to people to try themselves. Then if they are not succeed, they could help them. Thank you.
Prof. Ongolo.
Okay, thank you, and thank you for the interesting questions. The first answer is to those who are at the university, at the Polytechnic, or in other faculties. There is a whole room of research. In my presentation, I just put out a skeleton of what are the main areas of research that are possible. To have one very practical activities is around algorithm for diagnosis. Can we have contextually adapted algorithm for diagnosing cognitive impairment? Can we have prediction models? Can we have apps that could actually help us having self-assessment on are we actually getting cognitively impaired or not, to provide an answer to the guy from Polytechnic. Mais pour les autres, le champ est complètement ouvert. Rien que sur le discours. Tout à l'heure, j'ai posé la question, c'est tout un sujet pour ceux qui font géographie ou qui font littérature. Comment on appelle celui qui perd la tête quand il devient vieux dans nos villages? Et ça nous aiderait pour savoir, ce qu'il y a. Et on sait également que dans certains de nos villages, il paraît qu'il y a une alimentation qui fait qu'on reste jeune. Il y a des villages de centenaires au Cameroun. Qu'est-ce qu'il y a dans ce village-là qui font que les gars ont 90 ans, ils peuvent courir, ils peuvent marcher et ils ont tout. Il y a beaucoup de choses qui peuvent comporter des sujets de recherche. Donc, de la même manière, la question sur les traitements, le problème éthique fondamental avec la démence ou la maladie d'Alzheimer, pour citer celle-là, est qu'aujourd'hui, il n'y a aucun traitement démontré efficace. Le deuxième problème est que dans le contexte camerounais en particulier, nous n'avons pas un protocole standardisé de prise en charge. Parce que la réhabilitation, c'est vrai, le docteur Temgwa est là, on n'a pas de consensus sur, une fois qu'on constate que quelqu'un est en train de perdre la mémoire, qu'est-ce qu'on lui propose comme protocole pour le prendre en charge. Et ça pose donc la question, sur le plan éthique, ça sert-il à quelque chose de diagnostiquer une maladie alors que nous n'avons pas un protocole de prise en charge? C'est une question éthique centrale. Maintenant, les autres problèmes, partout dans le monde, il y a des lois qui protègent ceux qui sont vulnérables. En particulier, lorsque le cerveau est touché, il y a des mécanismes de protection. Est-ce que nous avons ça? Nos amis du ministère des Affaires sociales ont dit oui, personne handicapée, peut-être. Mais le vieux qui commence à perdre la tête, ou le jeune, nous, avec le VIH, nous avons vu des jeunes présenter des tableaux de démence. Et lorsqu'on a posé ce diagnostic, qu'est-ce que le médecin doit faire? Tout à l'heure, je le racontais comme une blague, mais j'ai dû aller chez le notaire parce que c'était un conflit ouvert dans la famille. J'ai fait l'erreur en tant que radiologue d'avoir donné le diagnostic à un enfant qui a amené son père faire une IRM Et le tableau était vraiment caractéristique, sauf que l'exploitation qui en est faite après. Et parce que justement, il n'y a pas, il faudrait faire intervenir le juge pour déclarer quelqu'un inapte à prendre des décisions et le protéger dans des décisions. Il y a des histoires de personnes qui signent des chèques sans provision ou qui dilapident de l'argent parce qu'ils ont ces troubles cognitifs. Et à la fin, on constate qu'en fait, ils étaient inaptes intellectuellement. Le problème est urgent, à mon avis. S'il y a bien quelque chose qu'il faudrait faire très rapidement, c'est d'avoir ces mesures de protection légale des personnes qui sont en train de perdre la mémoire. L'autre problème éthique dans la prise en charge, c'est, OK, vous m'envoyez un malade faire une IRM parce que vous suspectez qu'il y a des troubles de la mémoire. Est-ce que je dois faire cette IRM? Logiquement, pour que je fasse un examen malade, il faut qu'il donne son consentement éclairé. La tête a commencé à jeter l'air, comme on dit au quartier. Qui me donne le consentement? Il y a un autre problème, qui est la personne de confiance de ce patient qui vient parce qu'il commence à perdre la mémoire? Qui est l'accompagnant qui a le droit de décider ou de signer à sa place? N'est-ce pas? C'est autant de questions auxquelles, de manière assez rapide, je pense, parce qu'autrement, nous aurons un gros dilemme en tant que chercheurs de dire nous faisons la recherche sur les patients qui ont une dégénérescence neurologique ou une maladie d'Alzheimer, alors que les mécanismes ne sont pas en place pour protéger ces personnes-là, c'est-à-dire leur reconnaître cette dignité humaine et que ce que nous faisons avec eux, nous sommes conformes à ce qu'ils ont accepté de participer à ces essais-là, ou alors qu'ils ont une personne qui légalement a le droit de signer le consentement à leur place. Ça n'a l'air de rien, mais c'est une question importante. I wanted to insist on this key priority, and if we are to get out of here and have an opportunity to convince somebody in the decision-making sphere, is we need to have a regulatory framework that protect those who are suffering cognitive impairment in their daily life. Because otherwise, the biggest challenge for us who want to do research on this, we will be asked who actually involve people in these clinical trials. If we don't have regulation of who is the one in charge, the mentor or the tutor in charge of the person that is involved in our trial, will really be in trouble. Access to medical imaging, we should express our gratitude to the government, because now we can say that there is no region in Cameroon where you can't have access to brain CT scan. The number of regions where you can have access to MRI has increased. The number of radiologists is also increasing, as well as the technician to handle this. And we have a room for doing research using medical imaging, and there is a field for the students in relation to artificial intelligence. We are using eventually frames from out of Africa. It would be interesting to actually look at what is going on in our own setting if we consider that there might be some biological or anatomical differences from those who were at the grassroots and those who've migrated from Africa to settle elsewhere. So the point remains access to medical imaging. A brain MRI you will need to disburse between $200 to $600 US dollars equivalent. depending on where you are, in a public facility or in a private facility. And the minimal salary is $100. So there's few people who can definitely not afford. And then it means that we need to find algorithm that will be based on probably mostly clinical observation than relying on MRI. And this is not accounting for all the other costs that you need to go to the imaging center if you are living Bertois to have a brain MRI in Yaoundé. You need to spend a day, and this extra cost is also borne by the family. I think I've provided answer to most of the question.
Yeah, thank you very much, Prof. Ongolo. And I want to thank the panel as I now invite the chair of this panel, Professor Anne-Cécile Zonkanye-Bissek, to bring the concluding remarks on this session. Madame le directeur, vous avez la parole pour les conclusions de cet intéressant panel et merci à tous les membres de ce panel.
Merci de me donner la parole. Je voudrais d'abord remercier l'organisation pour avoir associé le ministère de la Santé. C'est vrai que bien souvent on se réunit entre scientifiques pour discuter de choses et d'autres. Parfois on oublie les décideurs. Je voudrais excuser l'absence de monsieur le secrétaire général en ce moment qui a des obligations qui l'ont empêché d'être là. Je voudrais dire que personnellement, j'ai beaucoup appris au cours de cette session. C'est vrai que sur la santé du cerveau, en août dernier, on en avait beaucoup appris. Et je pense que la première étape, c'est celle-ci, vraiment de parler en des termes simples, définir les choses auprès des décideurs, de façon à ce qu'ils comprennent, mais pas seulement des décideurs, mais aussi de la communauté. J'ai retenu que la recherche est une étape essentielle, et j'en suis convaincue. Mais quelle recherche? Le professeur Ongolo a tellement insisté sur les notions de consentement et puis les notions d'accès aux éventuels traitements qui pourraient être disponibles et qui pourraient faire l'objet de recherches cliniques dans notre environnement. Je ne manque jamais une occasion de rappeler aux jeunes chercheurs, parce qu'ils sont là, ils sont présents là, ils vont mener des travaux dans le cadre de leur master, PhD, etc., thèse de doctorat en médecine, en pharmacie, etc., de leur rappeler qu'il y a une loi qui protège ce type de personnes particulièrement vulnérables. Donc, il faut y prêter attention. L'insistance du professeur Ongolo sur ce point est très importante. Alors, la diffusion des résultats de recherche me paraît être importante aussi pour, au-delà de la sensibilisation sur les pathologies, mais la diffusion des résultats de recherche me semble être importante à l'endroit des décideurs. Donc, je pense que nos pays se ressemblent en écoutant les autres pays. Je pense que ce genre de fora participe de cette sensibilisation, mais comme je le dis, il faut traduire ça en un langage particulièrement simple pour que les uns les autres retiennent. Je retiens cette idée parce que je suis là, à la place de ce secrétaire général, comme un rapporteur, comme les rapporteurs qui sont en bout de table. Cette idée de programme national, et c'est là où je voudrais répondre à l'interpellation qui m'a été faite. Ce n'est qu'un programme national, en effet, qui peut arriver jusqu'au niveau le plus opérationnel pour la mise en œuvre de la politique qui aura été élaborée. Donc, je retiens la proposition et les perspectives d'élaboration de plans stratégiques. Je n'ose pas dire plan stratégique des démences ou de la santé mentale. Je crois qu'il faut continuer à faire le plaidoyer, mais je pense sincèrement qu'une intégration va être salutaire, parce que si on vient pour la santé mentale d'une part, en tout cas les démences ou Alzheimer d'autre part, il me semble qu'il faudrait vraiment insister sur l'intégration de toutes ces pathologies de façon à ce que le programme national ait les moyens et d'ailleurs soit assez solide pour que nous arrivions à convaincre les décideurs de le mettre en place. Je retiens aussi l'exhortation qui a été faite que la couverture santé universelle, si elle doit s'interroger, parce qu'elle a commencé par une première phase qui intéresse les femmes enceintes et les enfants de moins de 5 ans, si elle doit s'intéresser aux personnes âgées, prennent cet aspect en compte. Donc, je remercie vraiment les organisateurs pour la pertinence de la tenue de ces assises. Merci.
Thank you very much. Thank you, Chair. Thank you, panelists. And thank you for all your questions that made this session very, very interesting and worthwhile. I pass the floor now to Prof. Fonga while inviting the panelists to get back into their seats.
Thank you, Prof. Jamshi. What a wonderful her question about Alzheimer Association and request to include some of the topics. And we have the right person here. So for this last presentation, it's my pleasure to introduce Professor Crystal Glover. She is an estimated applied social psychologist and mixed methodologist at the Rush Alzheimer Disease Research Center. She is an associate professor of psychiatry, behavioral science, and neurological science at Rush Medical College, where she also leads the Outreach Recruitment Engagement Corps. Dr. Glover is a dedicated researcher in health, emphasizes intersectorial and social cognitive processes to better understand cognitive and healthy aging across diverse populations. With a strong commitment to inclusivity, she collaborates closely with the African American, Black, and Hispanic Latino communities group that have been historically underrepresented in research. Most important, Dr. Glover is the inaugural editor-in-chief of the Alzheimer and Dementia Journal, the Behavioral Socioeconomic of Aging. She is also representing the Alzheimer Association at this conference. Please join me in welcoming Dr. Crystal Glover.
Hello, everyone. Thank you to my newfound brothers, Alfred and Bernard, as well as Yimbe and my newfound sisters, Carol and Golda. It's a pleasure to be here with you today. I am Crystal Glover. I will give you a roadmap to how we'll structure our time together today. Here I'm representing the Alzheimer's Association, particularly for the Alzheimer's and Dementia newest journal that I'll speak about. So I'll give an introduction to myself, my editorial board, but more importantly, tell you about this journal, what it means to you, and how you can publish within this new establishment. So I am Crystal Glover. As Bernard indicated, I've recently transferred from the Rush Alzheimer's Disease Center in Chicago to the University of California, Irvine. So I've been very fortunate to be able to serve many leadership roles, including in their UC Irvine Alzheimer's Disease Research Center, the Alzheimer's Clinical Trials Consortium, as well as with Africa Fingers. However, something that I'm so excited about is being editor-in-chief of the newest Alzheimer's Association journal, Alzheimer's and Dementia, Behavior and Socioeconomics of Aging. I could not do this without my deputy editor. They are right now, or I think yesterday, leading the Pittsburgh Neuroscience Next Hub. And so I sent these slides to her Rush, and so really want to big up her here for all of her commitment to the new journal. So something that it starts with is that this newest piece is the newest member of Alzheimer's and Dementia family of scientific journals. There are 4 overall journals in which my newest piece is a part of. We have Alzheimer's and Dementia. That's the flagship, if you will, and you may have heard about that. We also have Alzheimer's and Dementia, Diagnosis, Assessment, and Disease Monitoring. And we also have Alzheimer's and Dementia, Translational Research and Clinical Interventions. Last year at the Alzheimer's Association International Conference 2024 in Pennsylvania, so in Philadelphia, we launched this new journal, Alzheimer's and Dementia, Behavior and Socioeconomics of Aging. So that means that this journal is less than a year old, and you're going to hear about all the progress that I've made, my editorial team has made in that short amount of time. So our primary aim for you in this room is focused on how we can rapidly get out your findings, your perspectives, your ideas, and also how you may want to apply all of your research focused on behavior, social, cultural, and economic factors. So you can think of those things acting independently, but also interactively together. But even more so, in my journal, we're not just talking about dementia, Alzheimer's disease. We're talking about diverse trajectories of aging. So when we speak about brain health, that's for the journal for you. So our general scope does focus on structural, social, and individual determinants. So that's ID by behavioral, economic, social, and related factors, all thinking about how diverse aging and dementia trajectories come to life based on these factors. But more so, it's not just from the perspective of older adults. We're thinking about caregivers, support partners, healthcare providers, policy analysts and policymakers, but also many in this room, researchers and scientists. So I'm thinking for this journal not only local and national in the United States, but globally. So some of the key facets for us is that we strive for equity throughout all of our processes, whether it's the peer review, whether it's going with my editorial, whether it's dissemination status. We're thinking about how to get this out to everyone. That means we're highly encouraging research perspectives that are not just focused on challenging and barriers, but also areas of resilience, resistance, coping, and thriving. Because indeed, although we face many challenges, many barriers, we are still here by being a resilient group of people. So we want to hear what are those factors associated with that resilience. So I also encourage people to partner with other research areas. How can you use different methodologies from sociology, genetics, bring them together to understand diverse aging and dementia trajectories? That means we welcome diversity in methodologies, methods, and data analyses. So the ultimate objective here is my strong belief that we have a lot of research, and this is great, a lot of ideas, a lot of perspectives, but I'm really interested in knowing with this journal, how can we apply it? How can we create practices, whether in healthcare, policy, different guidelines, interventions, tools, measurements, but also any other evidence-based materials. This means I would like to hear about health outcomes, healthcare, and supportive services to eradicate these disparities and facilitate the equity that I think all of us are discussing in this room. This gives a nod. I hope that the organizers will provide slides afterward. This gives a nod that it's just not me doing this work. I am surrounded by an editorial board that is across the globe. We have Rufus Akinyemi, who is in Nigeria, also holding a Neuroscience Next yesterday, or was yesterday. We have Jennifer Lingler. We have people in Argentina, as the United States, focused on 8 distinct areas. So research, design, and conduct, behavioral and health economics, bioethics and legal and regulatory considerations, which we've talked about quite a bit here, caregiving, global perspectives, which I think is important in this room, how do we provide health care, mental health, which is brain health, and public health. So just since we launched this journal, what was that, maybe 7 months ago, we've already received over 56 manuscripts. So that means we've accepted 8 of them, 24 are under review, 9 are out for revision, and 15 I may have rejected, okay, just due to quality pieces. So, well, let me go back. In a minute, I'll tell you that our inaugural issue is coming out on March 1st. So I'll give you a snapshot of those papers. Some of the key themes is all around global perspectives. So we're thinking about what's dementia prevalence and trends, risk and protective factors, across diverse groups of people, including Ethiopian here on the continent of Africa, as well as Black and African American in the United States and beyond. One of the big topics is everything about economics, everything about finances. How does that impact me getting older? How does that impact my family? And also, how does that impact me as a woman now in terms of how may I save and plan for the future? But something that I stress to my board, to people that look to publish in the journal, is that there's interconnectedness between all of these topics, all of these areas related to behavioral, social, and economic areas of aging and dementia. I don't know if you can see this as well. I kind of finished these slides when I was here, but this just gives you a kind of snapshot of the 6 publications that are now up. They are on the website. So something that I've stressed is the rapid communication of findings. So the minute that your paper is accepted, it goes up on our website. It is collated into an issue that is established quarterly. So thinking of this, if you're a new investigator and you want to get your findings out there really quickly, early, think of this journal. So we have our inaugural piece coming out March 1st. I've provided QR codes so you can scan and take a look at that. I know that I have a limited amount of time, so this QR code will take you to my editorial. The editorial breaks down every single piece of the journal, from how do we define behavior, social, cultural, economic, and how we're looking to have these different pieces applied in healthcare, in different policies, etc. So something I think is very relevant to everyone in here, to consider publishing with us. We do not want financial barriers for you in this room. So that means at the bottom here, highlighted, we have an agreement with the country of Cameroon and other low and middle income countries that you will have an automatic discount or an automatic waiver, depending on your institution. So please do not let that be a deterrent for you to get your findings out there, submit to BC, and really engage with the broad scientific community about the talent we have in this room. So I tried really hard to stick to time. I will be around the full conference. You can reach me here on social media. Here is my email as well. So I welcome your questions. I'm around, and thank you.
Thank you so much, Dr. Glover. Before we continue, I will ask the AV team to connect to the Alzheimer Association platform, please. The AV team should connect to the Alzheimer Association platform.
During the last part of the program, we'll have the opportunity to share with you current projects that we are working on already at Brain and how you can get involved for those of you who are interested. And it cuts across the board for people who are in medical school, people who are doing PhD programs, people who are in residency and training, but also professionals who are already on the field and who would also like to contribute to the work that we're doing. So we would have those discussions in the afternoon. We would also have a testimony from people with lived experience, because we can talk here as scientists, but it's important for us to hear from those who are actually caregivers and whose side of the story is most important. We will have prize awards for the best abstracts. So please do look around, read, listen to the presenters, engage with them, learn about their work. They've done tremendous work to be able to prepare those abstracts to share with you today. So get involved. Those who are in medical school, learn, connect, so that for the next conferences you can prepare abstracts as well. And then we would have the closing ceremony, which would end at 5. So thank you very much. And I hope that the presenters for the abstracts, the posters, are already outside so that we can join them. Thank you.
Puisque le Cameroun est bilingue, on me demande de faire un résumé en français. Donc, ce que je disais tantôt, c'est qu'on sort maintenant pour la présentation des posters et tous les présentateurs doivent déjà être à côté de leurs posters, comme ça l'assistance va passer les écouter. Et après ça, nous allons avoir la pause déjeuner pour revenir à 15h30 pour la dernière partie du programme qui va se terminer à 17h. Merci beaucoup. Okay, the poster presenters are outside, so feel free to just walk out and meet them at their posters and have a scientific exchange. Thank you.
It's on. I talk like this. 1, 1, 2. You know. That's the sound for the mic. What? 1. I want to use it for the choir. How's 1? 1? It's supposed to be passing. 1, 2. 1, 2. Okay. 1, 2. 1, 1, 2. On 2. Actually, since it captures the way it's supposed to capture. One, 1. 1, 2. Sure, capture the way it go capture. Yeah, but it's not.
No shows here against for increase the
No.
this thing.
They increase the. Where do they increase the volume on it? Do they increase the volume?
On that one there, the
On that
receiver. Which one is the receiver?
It's the receiver, yeah. One, 1. 1, 1, 2.
Even these people do not know.
1, 1, 2. Well, I think it's better. 1. Because I want to be as high as possible. So I'll just keep it in front of them so this is capture.
And then you put it exactly at this thing, around.
How to put
this around
this document down. 6
6
GB minus 1, 2. 1, 2.
Now the easier way for it. Where to? Yes. I want this one, you know that one. Say it again, maybe.
1.
This one is the one walking in reverse. This is the loudest instead. So where it was instead was better.
1, 1, 2.
Yes.
1.
qu'est-ce que j'ai dit? Qu'est-ce que j'ai dit? Attends, qu'est-ce que j'ai dit?
C'est tout ce quand il y a 60 cents.
Non, j'ai pas dit
Tu vas nous
60
dire,
cents.
tu as compris quoi?
Il est arrivé, le son jouait, le son de 50 Cent. No, it's not the one.
Yeah.
I was like, he came in and then the music was playing. He asked, no, if you leave me, maybe take it to
No, pas like try to get it.
I was like trying to give you the vibe of the music, how the music was bouncing.
Okay.
So he came in and asked, like, who is playing that sound?
Voilà.
Tu veux pas saluer ma grande sœur?
Ma grande sœur
Those who say you are a bad boy. When I show you that minute, I'll show up.
I was not standing. I'm feeling guilty. You can't stop being a prophet like this.
What happened to me? Now,
see, you're a being woman, and you start saying something.
Yeah, it is woman.
Voilà, donc, pray, don't move back. We go move back. Don't move back. Thank you. I say, why don't you think you want to take you? He said, if they think I don't want to do it,
President want me to move your money.
Antiquity.
I want to say something that. I show you the book.
That's why I feel that thing. Doctor say, get me anybody. Money is not the problem. Get me anybody. The president now, then I'm going to Thursday on a Friday. No. Like last week, so the visit on Monday. Okay, you're not even there. You're not there. First test. Okay.
Was putting somewhere else.
Yeah. The first time we did a test now. That thing they want to do.
Press. There was no agreement that I'm giving you no detail, right?
No, there was no agreement.
Because my machine is just saying that I don't like my machine already.
Everybody, wait, who is this?
I don't know for my machine. I just came in. Better to talk about late. Night.
For 5. If they hold me for 5 for here, unless I enter and Cameroon and I try them.
And that bro, I just ever anything about go back.
No, if press give me time, it's fine. You don't give me 45 and they go me for 5. Agreement is agreement. I mean, you sign a contract. How they go fix this thing? I never get the logic. I know say yes, they should take this thing for town. I know say they buy this thing online. They should go on school move do and shit new one. It don't look like thing where they don't move fit my new one.
Oh my God.
So they go straighten and
Say, Fred. I beg boy. I beg.
change that song.
I beg boy. I do bring that beg boy. Now, me my voice on that tempo. Well, I leave that one. You know, I ain't listening to Joe Fred. She's so.
Hey, I beg.
I ain't saying unchangeable, reliable.
Okay, wait. What I really like about what Lagos is
Just play that other strong, that piano thing. That uncopyrighted thing. Eh? No, I just play gospel. Let me play those uncopyrighted songs. Those piano.
Sharp now we're in the middle of gospel.
I like the middle of gospel. Well, I just play jazz or something. Not that. I don't want to move that tempo. You don't cancel.
Good afternoon, ladies and gentlemen, and thank you for being here up till this point. We are just waiting for the representatives of the Ministry of Health and Higher Education who are on their way for us to start the ceremony to close the program. But we invite the Faculty of Medicine Choir to give us some beautiful music while we wait. And at some point, we're going to have a presentation from Professor Bernard Fongang on the Africa Initiative for Bioinformatics Training in Neurodegenerative Diseases. So this is a special program. It's a free training that Brain has been hosting with faculty from STAC. And it will be good information for those who are interested in participating in that training. Shortly after that, I'll be back up here to talk about the building unique infrastructure for large-scale dementia research in French-speaking Africa, which is a project that Brain is piloting with headquarters here in Yaoundé, which would be good for those who would want to be involved or contribute in one way or another. Thank you so much.
Il est niveau 1, ne connaît pas. Quoi, il a dit quoi là? On transpose.
Articulo mortis caelitus vivires, Deo adjuvante non timendum in perpetuum, dirige nos domine ad angusta per angusta, siccitura dastra excelsior, 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 my soul shall be nearer, my God, to thee. Dirige nos domine ad angusta per angusta, siccitura dastra excelsior. In articulo mortis caelitus vivires, Deo adjuvante non timendum in perpetuum, dirige nos domine ad angusta per angusta, siccitura dastra excelsior, 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 angels to beckon me nearer, my God, to thee. Dirige nos domine ad angusta per angusta, siccitura dastra excelsior.
La série peut guider. Adjon. Dis madame, va. Dis madame, va.
Adjon, wananje, dim madam wa Jerusalem. Adjon, kwalale, dim madam wa Jerusalem. Dim bosan enyolo, okasakweti bosan, mumayama musango, dim madam wa Jerusalem. Dimma, bosan enyolo, okasakweti bosan, mumayama musango, dim Madangwa Jerusalem, oh Jerusalem, mano abeno. Madangwa Jerusalem, Jerusalem, mano sabeno. Madangwa Jerusalem, bosa nenyolo, okasa kweti bosa. Mungayama no sango, Madangwa Jerusalem, bosa nenyolo, okasa kweti bosa. Mungayama no sango, Madangwa Jerusalem, Madangwa Jerusalem, Madangwa Jerusalem, Madangwa Jerusalem, bosa nenyolo, okasa kweti bosa. Mungayama no sango, Madangwa Jerusalem.
very much to the choir of the Faculty of Medicine. Can we give them a round of applause? So we're going to start. There will be a slight change to our program. The Secretary General is almost here, but when he comes, we're going to do the national anthem and do all the official items on the agenda that we're supposed to do. But now we're going to hear from Professor Bernard Fongang, who is going to talk. He's the program director for the AI Bond, the Africa Initiative for Bioinformatics Training for Neurodegenerative Disorders. And he's going to tell us briefly about what the program is, what it has achieved. And I encourage everyone who is interested in learning more, widening their skills in the dementia space, especially from a computational standpoint. This is a very unique opportunity that is available to to students and professionals from French-speaking Africa. And so please, with a warm welcome, we would like to receive Professor Bernard Fongang. Thank you.
Thank you for the presentation. So as soon as we have the slide, we can start. Yes. The Secretary General is there. So join me to welcome the Secretary General. And this talk, the AI band was supposed to happen tomorrow. So we're going to keep it tomorrow. And then we go back to the original program. Thank you. You have this one? Thank you so much. My name is Bernard Fongang. If I can have my slide, please. I am assistant professor at the Glenn Biggs Institute for Alzheimer and Neurodegenerative Diseases. This is a UT Health San Antonio. And I also want to highlight that I'm a pure product of University of Yaoundé 1, a Faculty of Science. So today I'm going to talk about something very important and unique that Stack and Brain came up with, which is to develop computational capacity for Sub-Saharan, for African scientists. So I have nothing to disclose. So I'm going to first talk about the need for expertise in computational and biostatistics and bioinformatics. Then I will talk a little bit about the AI-bound program. Like we say, was developed through the collaboration between UTF San Antonio and Brain. And then I will show you how to do if you want to join the AI-bound either as a trainee or as a faculty mentor. So we've seen this picture a lot, and Professor Jamshi showed that this morning. They're showing the contracts between the plasticity of dementia data in Africa in general. And this is from a KME in Ireland 2022 showing the number, the lack of data in dementia research in Africa. And, but things are changing as you're going to hear from Dr. Yembe Njamshi, that there are a lot of opportunities, in fact, coming from abroad, and then try to help us to develop this, collect this data, and then try to understand the risk factor for dementia in Africa. So some of these are included the READ ADSP, but you also have different capacity building program from the Alzheimer Association, the Global Health Institute, and then, as I said, you're going to hear in a couple of minutes from Yembe Njamshi about this program, a newly funded program funded through Brain and Stack by the National Institute of Health in the United States, which is the building unique infrastructure for large-scale dementia research in French-speaking sub-Saharan Africa. So this one is focused on French-speaking sub-Saharan Africa, the first 2 years in Cameroon, and then the from third to 6 years in CRA, in Central African Republic, and Chad too. So in parallel to this effort by the funding agency, we believe that we need some effort to train African scientists how to collect this data, how to analyze data, and how to interpret and disseminate this information. This is typical. We want to move from the path where the data, everything is exported, and then we don't even know what happened to the result. But if we train a workforce of Africans to collect, analyze, and do the data, then we could move to the precision medicine, as Professor Ruiz was talking about. So there is a need to consolidate training for AGRD research in Africa. So research in low and middle-income countries in general suffer from not only the lack of funding, but also the lack of relevant in-country training in biological data handling, mining, and analysis. So training such a workforce will help alleviate many of the challenges presented. For example, you could train people how to create and adapt research tools that are tailored to the specific population. You could train people how to handle massive amounts of data, RNA sequencing data, single cell, single nuclear RNA-seq data. If you want to go to the world of precision medicine, this is where we want to go. You want these people to understand, first to understand what it is, but also to analyze and interpret the result and to disseminate the result in this population. And then there are several initiatives that exist. We have the H3 Africa BioNet. We have the African Biogenome Perspective, but none of them focus on neurodegenerative diseases. So, and one other reason why we really want to develop bioinformatics, biostatistics, bioinformatics, and computational expertise in Africa is that this training should also not be limited to genetics, right? We need things that encompass genetics, but to move to other omics data that are necessary to develop innovative precision medicine, as Professor Ruiz was saying this morning. If you want to move in that direction, then we need Africans to understand what it is. We need our young colleagues to try to start learning what the data are and then try to understand the analysis, try to perform the analysis. So we started the idea in 2022, Professor, 2022 in Nairobi, when we sat down and said, we really need it. And then we met again, subsequently met again in San Antonio twice, just to brainstorm the ideas and how to develop such a program. And then we come up with the AIR-bound. It is the African Initiative for Bioinformatics Online Training in Neurodegenerative Diseases, AIR-bound, which aims to build computational capacity for sustainable dementia research in Africa. I want to confess that it's not only bioinformatics right now. I think we moved from just doing pure bioinformatics to do a lot of biostatistics, because we understood that most of our trainees were MDs, medical students, that do not understand things in biostatistics, how to analyze the data, how to have table one of the publications. So we start from the very basic, how to first design a study, how to collect the data, where do you need, Professor Bellisso was talking about the informed consent. We need that informed consent. We train them how to do all that. And so Airbound is a free structured training program designed for African scientists focusing on biostatistics and bioinformatics in neurodegenerative diseases. So the program element will made of a core component that include coursework in biostatistics, bioinformatics, hands-on project, I think. And this is one of the particularities that we have. If you want to do research, you can start with Airbound, whether you have a project or not. If you have a project, that's fine. But if you don't have the project, we have a full core of faculty, and we see that in a minute. That will help you develop project based on your level of expertise. So the Airbound concept was just published a couple of months ago. If you want to download the paper and see what it is and how we manage to navigate all the burden associated with developing such online training program in this environment. So this is the leadership here. We have Dr. Sudha Seshatri and Gladys Maestre from the STAC. The STAC is UT San Antonio and UT Texas Rio Grande Valley. We have Professor Njamshi from Brain, but we also have our site coordinator, people who will, in fact, they work every single day with our trainees, try to organize everything. Dr. Binya Mayele and Dr. Yannick Wadop. But we also have a big core of faculty that include bioinformatics and genetic epidemiology and biostatistics and mathematical modeling. So we have Dr. Modley Surugroup Ramaj, Dr. Chuchu Jian, Dr. Alfred Fonte, and then we have Professor Himali, Professor Seke, and Professor Abdong Atangna, and Dr. Nono, which are in fact part of the purely computing part. But we understood that most trainees from the Airbound will come without any real neurodegenerative disease background. So we also need a pool of neurologists, neuropsychologists to train them to understand what is the disease, what is the nature of the disease, what is the state of the research, what are we looking for. And then this include, again, Professor Dr. Binya Mayele, Dr. Cyril Konlak is here, Dr. Yembe Jamshi, and Dr. Emmanuel Penge from DRC. And those, all the core faculty that are involved in weekly activities that include pre-lecture material, lecture and hands-on tutorial, and post-lecture, but also mentoring and support. What it means is that they will mentor trainees from paper writing, grants writing, and other. Airbound clearly now have 4 modules. I think we're trying to extend to more, including imaging. But currently we have 4 modules that start with programming. If you want to do computational, at least you need some sort of background in programming. That doesn't mean that you need to know programming before coming. In fact, one of our greatest successes is in this room, Foba Akom. She came with no background in computing or whatsoever. And then she became a really good part of Airbound. And she ended up submitting abstract. And now she's going back to do her master and continue with the PhD. So we also include neurodegenerative disease, as I said. We have genetic epidemiology. We have integrative omics to move to the direction of precision medicine. So, and then we also provide a lot of services, like access to Texas high computing cluster. So we understand that to analyze single-cell RNA for sequencing data, for example, to analyze single nuclear or even gene expression data, you need access to cluster. So all Airbound trainees have access to Texas cluster, so where they connect, they can do the computational work, They also have access to clinical imaging, genetics, and omics and ADRD data. So, and this is my favorite part, in fact, we have a full support. The airborne faculty fully support trainees for grant writing, for project development. And I will share the news with you at the end that we have just submitted for a couple of hours. Trainees have just submitted a couple of grants, which is what we're looking for. We want all of you, all of us, to work in an environment where you can submit your grant, whether you're French-speaking or English-speaking, right? You want to train you how to develop a grant, a competitive grant, not only a competitive grant, a grant that can be funded. So this is what we aim, and that's my favorite part of it, how to train our scientists to submit grants and write papers. So this is the 2023 cohort. When we first started, after we discussed with Professor Njamshi, we start advertising the program. In 1 month, I think, or less 1 month, we received about 173 applications from 17 countries. Those countries are represented there, and with a different level of expertise and career stage. I think Nigeria and Cameroon made the most. In fact, Cameroon was the first with, I can't see properly, but Cameroon was the first and Nigeria was second. And then we train early scientists, PhD, but also train the trainer. And this is one of the beauty of this. We currently have also trainers from Uganda, for example, who are full professor and that will also now continue training their own trainees. So, and the module are there. I think what happens is for the 2024, I think this should be 2024 cohort, we start in December. In December with basic programming, we selected 3 languages, R, SAS, Python. And then we have introduction to biostatistics, which is a main component of our program. So 2 months of biostatistics. This is huge. And then we have, in February, March, we're going to have neurodegenerative diseases, and with Professor Dr. Konlak and Dr. Njamshi here and other. In March, April, we're going to have genetic epidemiology, genetics, and then April, May, we have omics, the omics module, and after May, now we're only talking about project development and grant writing. So this is some of the projects that some of our trainees are currently working on. The urine lipid biomarker, vascular contribution of vascular risk factor to dementia, for example, gene and clinical significance of neurovascular pathology, ADGY for minority population, using, I think, data from the South Texas. But also people working on protein from purely structural bioinformatics working on protein. So in 2024, this is just a comparison between year 1 and year 2. I think we increases the number of countries covered. In 2023, we had 17 countries. In 2024, 23 countries. And the number of applicants also increases, right? We have about 173 applicants in 2023 and 220 in 2024. So gender distribution, which is very important for everyone, including the Alzheimer Association, is really looking at, we need to have equal distribution of gender in research, and they're very keen on that, so we're looking at those things too. And although we still have more male than female, but I think we try our best to have also more female. So in career distribution, I think we have more students this year, and this is perfectly fine. I have a couple of students, airborne trainee in the audience, I think. So this is the timeline for this year, and what we already have is we have submitted several abstracts, including for this conference. For the main Alzheimer Association conference in Toronto, so our trainees submitted about 6 to 7 abstracts, which is not bad. We have submitted 2 grants, Arrow 3 grants, and our trainees have submitted LOI for Alzheimer Association, and they're going to we hope that they're going to be invited to submit the full application. We still continue with weekly mentoring session every Friday from 10 to 12 Central Time. We have meetings with all trainees, past and current trainees, to discuss their project, discuss the problem that they have. And I would say all of this is free of charge. I mean, when it says free of charge, it's free of charge for you, because technically the university is paying the faculty to be involved in this. So it's free of charge to you, but paid by the university if you want. So now, if you want to join the AI-bound program as a student, you can scan the QR code. I would really encourage all of our trainees, not our residents, not this year because it's closed, but next year, I would really encourage all of them to apply. It's free. Everything is free. It's online. But one of the reasons, and you're going to hear you from Dr. Njamshi, is that we got the Build FSA grant will include a part from French-speaking sub-Saharan Africa. So we're going to train among all the AI-bound trainees. We're going to select those involved in project and have them for a two-hand session here in Yaoundé at the BRAIN headquarters. So if you want to join as a student, you can scan the QR code. If you want to join as a faculty, you're welcome to connect with us. We're always open to recruit faculty. So this is where everything starts. With this picture, this is at the Stack Hotel. This is downtown San Antonio. And this is where we start discussing, we materialize the AI-bound program. And this is all the support that we're receiving from different funding agencies, including the newly funded UG3 grant, the Build FSA grant that already started. So with that, I will like to thank you all for your attention. And if you have any question, I'm ready to take. Question? Room for 2 questions? None? Okay.
We need the help with the media team here for the slides. Please, another round of applause for Professor Fongang Bernard. It's a really unique opportunity, and again, it's free for the participant, even though it costs a whole lot for the faculty and the institutions involved. And I think that this is a good opportunity for us to build the capacity that we need, the skills that we need to build the infrastructure that is necessary in our context, which is very different. I'll just give a few moments for my slides to be up, and I'll be talking for 5 minutes so that we can start the closing ceremony. We're very thankful to the Secretary General of the Ministry of Higher Education, who is here in person, representing the head of the department, the Minister of State, His Excellency, Professor Jacques Famé Ndongo. And so I'm going to talk briefly about the Build FSA project, which you have heard about in the course of the discussions. The picture that Professor Bernard showed a few moments ago was taken in Texas, in San Antonio, where we had this meeting thinking about how we can build infrastructure and research in French-speaking Africa, starting from Cameroon, leveraging the fact that we're bilingual, and so we speak English and French, and we can then help our French brothers to get on board with English research, and that's the gap that we're kind of trying to fill with the Build FSA project. So the first thing was for us to set up a training program, which he has presented, the AI Bond program, and basically we're training staff who are working in our institutions, in BRAIN, in other parts of French-speaking Africa as well. Thank you. in other parts of French-speaking Africa as well for us to build a capacity. A big thing that is important for me to highlight here is the concept of brain drain. And I become very personal and very sensitive about it because my life as a baby and as a young man has been characterized by a huge sacrifice that my father made, because I was born in Switzerland. When he was doing his medical training, his residency in Switzerland, and he was encouraged to stay in Switzerland, and so I was born there, and I kind of had a different experience when I was born. And he took the decision to come back to Cameroon, which had a huge impact on our family, because he felt that he had to serve his country. And so when he came back, there were days that we didn't have food at home. He consulted in his car for a long time before the first unit in the Central Hospital was created. We basically, as children, grew up going to the Central Hospital to clean the hospital, to fix the lights. And personally, I'm very grateful to the government. I say the government gave me everything because my training as a medical doctor didn't cost $1 million francs. From nursery school. I've been all in public schools. And so I feel that it's important for us as Cameroonians to actually build our country. It is our responsibility as Cameroonians, and in the science world, we look so much for the government. We want the government to do things. I know that our Secretary General is here and we'll be echoing some things to him for him to feed back to the minister and the government. But at our level, there's a lot that we can do in building our skills, in creating the jobs that we need. Even as PhD holders, we are supposed to be creating resources, writing grants, getting projects off the feet, and helping our government to do what it's supposed to do. So it's in that background that the Build FSA project came to light. And this is a project that is in 2 phases, where we are trying to build the infrastructure to study dementia in French-speaking Africa. And so this is a slide that you may see very often in the course of our conversations. Less than 10% of the scientific production on the continent is from French-speaking Africa, as far as dementia is concerned. And it's a reflection of many factors, some of them cultural. Some people will say there's lack of funding. But I think we need to do a better job at getting ourselves organized as a team. Cameroon is a very diverse country, 250 plus ethnic languages, and we have a big role to play in providing proper healthcare and brain health, which is our focus, to our populations. And so we're trying to disentangle that. So the Build FSA project, which is starting this year in Cameroon, is going to have 4 main cores. One of them is an education core. You've heard Prof. Bernard talk about the AI bond, which we're going to be leveraging to train people who want to stay in the country to work, to build our country together, to build brain health in our countries. And so we're getting a lot of support from the government. I mean, our president sent the prime minister here a few months ago to say that brain health is important. And so I think that's the greatest support that we can have. And as researchers, we need to do our own side of the work in building the skills and building the resources and infrastructure that we need. There's going to be a clinical core as well to recruit, a biomarker core because we're going to be taking blood samples for genetic studies, but also microbiome. And there'll be a data core that will be doing all of the analysis. So how is this project phased? It's in 2 phases. We call the phase 1 the UG3 phase, which is 2 years. And in the first 2 years, we're building the administrative infrastructure. We're going to be training staff who are going to be working with us. These are people who are in hospitals, who are working, already providing care, others in research centers who are already doing research, and some people who may be sitting in the audience who just have an interest, and maybe some background training in that field. The brain is going to be launching recruitments. We have launched already, but continuing to launch some more recruitments to have people trained to work on this. But the big bulk of this phase of the project is about tools. Throughout the conversations this morning and early afternoon, we spoke about how difficult it is to find appropriate tools in our setting because of the language, because of how diverse we are. But it's a challenge and a huge opportunity for us as a people to produce some evidence to the world that is very unique and that can be a model to many other diverse places. So in this phase of the project, we would be developing and adapting different tools, clinical tools, but also neuropsychological tools that we would use to screen, but also do the phenotyping, clinical phenotyping of the different dementias in our area. And it was nice during the poster presentations to connect with a neurolinguist who is currently at the University of Yaoundé 1 and have very interesting conversations about how they can contribute to the work that we're trying to do. At Brain, we're very key and focused on doing research that is meaningful to the community, that is meaningful to our patients and meaningful to the people that we see in our communities, not just research for research. And Prof did a very good job in his presentation of showing the bench, bedside, backyard concept, because brain researchers all around Brain are people who are working either in the communities, working in the lab, like in the neuroscience lab where we're going to be tomorrow. You should all be there because we'll meet them. Some of them are teaching at the Faculty of Medicine, others are working in the hospitals. Most of the residents and neurologists are here in the hall. And so it's that team together that, of course, with our statistical cores and put together, that helps us to be able to generate data and inform policy in our nation. So this is a brief snapshot. I've gone 7 minutes above the time I wanted to, of the Build FSA project, which we're very delighted to be launching this week in Cameroon. And thank you very much for your kind attention. So we're going to move straight on into our closing ceremony. We would invite the Secretary General to come up to the podium. But before he comes up, please, I would like the protocol team to come and rearrange the seats up front. I would invite the choir to do a musical interlude while we rearrange the seats up front. We displace them for the picture. And would invite then the Secretary General and our guests from Central African Republic, from Chad, from Spain and the US to come up before we do the national anthem. After the national anthem, we would have a very brief presentation on the opportunities that are available to us for dementia risk reduction from Professor Augustin Ruiz. And then we would have a testimony from a carer, somebody who has lived experience with someone with dementia, tell us their story very briefly for 5 minutes. And then we would have the award of the top three abstracts that was submitted for this conference, which would be handed by His Excellency, the Minister of Higher Education, who is here represented by our Secretary General. And the Professor Jamshi would do a synthesis of the recommendations from the conversations for this conference. And we'll close with a word from the Minister of State, the Minister of Higher Education. So thank you very much, choir, for the interlude.
litali na yo Zambe yamba maboza na biso o litali na yo maboza 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 o litali na yo tata yambana biso o litali na yo tata yambana biso o litali na yo makabu 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 todo ya zambe betobesa makabu mafumu zambi makabu betobesa makabu mafumu zambi makabu Ecclesia todo ya zambe betobesa Ecclesia mafumu zambi Ecclesia betobesa Ecclesia mafumu zambi Ecclesia Zambe yamba maboza na biso o litali na yo Zambe yamba maboza na biso o litali na yo
Thank you very much to the wonderful choir of the Faculty of Medicine and Biomedical Sciences of the University of Yaoundé 1. Right now, we're going to invite Professor Augustin Ruiz to come up again. He gave us our keynote address in the earlier hours of the afternoon, and he's going to talk about briefly the opportunities for dementia risk reduction from a multidisciplinary approach to kind of consolidate all our discussions from the morning session. Thank you very much.
Okay. Thank you again for inviting me to this outstanding meeting, Neuroscience Next. Now I'm going to switch a little bit the registry. This morning we speak about genomics, and now we are going to speak a little bit about how we can, dementia management is something like a puzzle, and we need to manage all the pieces correctly. And this is the reason we need to create multidisciplinary groups to tackle the burden of dementia and to manage the problem. Again, these are my conflict of interest. The private and public institution I got funded during the last 5 years. Also, the people providing me my salaries. And again, this declaration is not affecting the message I'm going to provide. This is a completely independent message, what you are going to obtain, and my unique point of view. I think we have seen this slide at least 3-4 times during the morning section. This is simply to reflect and to remember you the importance of an early diagnosis of Alzheimer's disease, which is the main cause of dementia. It is important because identifying the people around the cases, you can also handle the potential risk shared by the people using the controlling of modifiable risk factors. You have seen during the morning session that controlling these modifiable risk factors, we can reduce the prevalence of the disease and the incidence in the future by half, mostly. So this is really important. We have to take into account. But again, controlling the risk factors is not controlling the people diseased, the people with the dementia. We need also a plan, as has been mentioned again, for having a plan for managing these cases, the cases of MCI, the cases of dementia. And we need to organize the services around that families and the patients and provide a very, very multidisciplinary service to them, because the problems around losing the ability of maintaining the independence and the daily life activities is absolutely amazing burden for not only for patients, but also for the families. You have seen also that this scheme has been updated in 2024. This is the Livingstone paper, has been refreshed. It was presented in Philadelphia in the last Alzheimer's Association International Conference. The new paper refined better the risks associated to different risk factors, and also added new risk factors, modifiable risk factors that can be controlled in a population. So really you need to get access to the patients as soon as possible. And now I'm going to share you our strategy. This is a common strategy in Spain for managing the cases. This is a conventional circuit to arrive to our memory clinics. We are tertiary services, providing specialized services for neurodegenerative diseases. What we realize is that with this approach, which is the conventional approach, we arrive usually late to the disease. We arrive when the patients already have over dementia, and we look for the way to circumvent this very, very long process to arrive to tertiary tertiary care for taking care of the patients. And this is the reason why we started thinking about to have some kind of engagement strategies associated to the conventional strategy and receiving patients from our general practitioners. And we founded the initiative of Open House, which is a way to get engaged with the community directly, the tertiary care getting into contact directly with the community using an open house strategy. This was a self-funded program of our organization in Barcelona, providing to the people free checks. We launched this in 2008, and you are going to see some figures. But the basic idea here is to shorten the time to get appropriate diagnosis. And the way to shorten that is really getting into contact with the community directly, because there are a lot of underdiagnosis cases, hidden cases in our society, as I'm going to show you. We provide during this Open High initiative something like, as I mentioned, a free pre-screening strategy where we provide a neuropsychological test, 20 minutes testing to the people and get a sample from them. And you can see that directly accessing to the community, we found a lot of hidden cases of psychiatric cognitive decline, but also 33% of the people arriving to Open House Initiative was endorsed of a mild cognitive impairment. And even 3.4% of them have already dementia. And we collected that cases directly with an interface with the community. So you can see that actually, despite our efforts in the public health system, we need to engage the community to look for the hidden cases as well. And this is happening in Spain. But why diagnosis of Alzheimer's is even more important right now? It's because of the new treatments, and we know that we need to remove amyloid of the patient as soon as possible to have the most effective effects of the new treatments arriving. Treatments are disease-modifying treatments. The first we have and has been approved in Europe and in the United States in the last 3 years, and now is the moment to get access to the patient as soon as possible to provide a disease-modifying treatment. So open house initiatives, engage of the community is now more important than ever. And for doing that, we need to generate precision medicine protocols, like I am showing you here, to look for the right subjects at the right time and providing to them the right treatments. If for that, you need to articulate a program, multidisciplinary one, comprising genomics, comprising neuropsychological analysis, epidemiology, and for testing biomarkers to look for the presence of Alzheimer's disease in living patients. So my take-home messages for all of you, you know well, dementia is a growing pandemic. And dementia diagnosis is delayed, and this situation is difficult in the implementation of secondary and tertiary preventative strategies. Primary prevention needs the identification of people at risk factor, modifiable or not, and genomics, of course. Prevention and precision is necessary. We cannot put the same treatment to anyone. We need to do a personalized medicine and only offering the right treatments to the patient that is worthwhile for them. Of course, we need to have an integrative view of the problem. It's not just about science, not about genetics. It's not about the antibodies against anti-amyloid. It's a burden of the society in which we have to tackle as a whole. And of course, we need to analyze the impact of the diversity. Probably the risk factors and the dynamics of dementia is going to be different here than in other continents. And it's because specific conditions or environmental factor and exposure very specific of these communities, and also probably a genetic background also different. So we need to gain insight, because with that information probably we'll get better solutions in the future. Thank you very much.
Thank you very much, Professor Augustin Ruiz, for that presentation. We're going to invite Ms. Monique Chiapi, who is a senior radiographer in the UK, but she's a Cameroonian, and she's going to talk to us about a personal story of a lived experience that she's going to share around dementia. As I said earlier, personal lived experience is very core at the center of what we do, because our actions, our strategies are supposed to benefit the people who are either living with dementia, caring for people with dementia, or as the physicians in this case may be providing support and medical care for these people. So please help me welcome Ms. Chappie.
Right. Oof, what a day. Right, I'll firstly say thank you to the team. I want to express my gratitude for the opportunity to share my lived experience. My hope is that by telling this story, we can raise awareness and prevent similar tragedies from happening to others. Okay. The title of this story will be A Tragedy, Misunderstanding, a story of my father-in-law, who was beaten and killed just from a population who were just ignorant about the disease. Okay, my father-in-law, may his soul rest in peace. It's, I don't know, but it was difficult to actually accept the situation that had happened to him. He was a kind and gentle man. He had lived a full life surrounded by family and love. But as he grew older, dementia began to take hold, slowly changing the way he saw the world. At times, he would forget where he was or speak to himself, lost in his own thoughts, but we understood. This was not madness, not something to be feared, just an illness that required patience and care. One morning, as part of the independence we still allowed him, he decided to take a walk. It was something he enjoyed, a small moment of freedom that brought him peace. But on his way back home, he encountered a group of people gathered in a village. He was talking to himself, caught up in his own world, unaware of the suspicious eyes now fixed on him. They did not see an old man with an illness. They did not see someone's father, grandfather, or loved one. Instead, they saw something they feared, something they did not understand. In the ignorance, they believed he was possessed, a madman, or worse, or a witch. And instead of helping him, they turned on him. He was actually defenseless, frail, and alone. He had no strength to fight back, no words to explain himself. They beat him mercilessly, their fear turning into violence, their ignorance leading to an irreversible tragedy. When we found him, it was too late. His body was left in the street, discarded as if his life had meant nothing. Our family was devastated, broken by the cruelty of what had been done. This should actually never have happened. Dementia is actually not witchcraft. It is not something to be punished. It is a disease, one that can happen to anyone. My father-in-law, Papa Philip, I'll mention his name because then, deserved understanding, care, and dignity, not brutality. His death was not just a loss for our family, but a failure of society to recognize and protect his most vulnerable. This is why awareness is so important. If people knew more about dementia, if they understood that those who suffer from it are not dangerous, but simply unwell, perhaps my father-in-law would still be with us today. My hope is that by sharing this story, we can prevent another family from feeling the pain that we carry. No one deserves to lose a loved one this way. No one should suffer because of ignorance. Let this be a call for education, for compassion, and for change, because knowledge can save lives, and no family should have to endure what we have seen, what we have been through. I don't know if you have time to say it in French or just a summary. OK. L'histoire que je viens de raconter, c'est tout simplement une tragédie qui s'est passée pendant que mon beau-père était malade. Il souffrait de la démence. Mais en fait, les gens pensaient qu'il était un sorcier ou bien c'était la folie. Et un jour, il a décidé de partir marcher. Et quand il revenait, il a trouvé un groupe d'hommes ou de femmes, d'hommes qui étaient dehors et qui bavardaient. Un groupe qu'il a en fait arrêté, il a battu et on l'a battu à mort. Et quand on est revenu, c'était déjà trop tard. Et c'était une tragédie vraiment qui a affecté la famille. Et on aimerait que cette histoire soit partagée afin que une histoire pareille ne se réalise plus. Merci.
We really want to thank Ms. Chappie for sharing her story. And one of the reasons we included this in the program was to create awareness because the behavioral change in reducing stigma starts from us, who are the actors, and we need to be ambassadors of carrying the right information to the communities in which we live. Thank you so much for sharing that story. I'd like to invite one of the Secretary Generals of Brain Research Africa Initiative, in the person of Dr. Leonard Ngaka. He's going to come here to share the perspectives from the Yaoundé Declaration on Brain Economy, Brain Health, and Brain Capital, very briefly. And immediately after that, I would introduce for him to do the prizes for the poster awards, and then we'll hear from Professor Alfred Jamshi on the highlights from the conference before we invite His Excellency, the Minister of State.
Thank you. Thank you very much, Wepner, for giving me the floor. Good evening to everyone, all protocol duly respected. I'll be presenting to us this evening all what has happened after the Yaoundé Declaration in August 2024. So I'll be talking on the Yaoundé Declaration on Brain Economy, Brain Health, and Brain Capital from Yaoundé to New York and beyond. This presentation is done by me, Dr. Leonard Ngarka, the Secretary General of Brain Research Africa Initiative, on behalf of the Technical Committee of the First African High-Level Science Summit on Brain Economy, Brain Health, and Brain Capital. The following uptake of the Yaoundé Declaration by Cameroon government on August 22nd, 2024, it was presented and discussed at the following meetings. On August 27th, 2024, the Rice University addressed one of the most pressing issues of our time, the brain's role in America's future, with Congressman Morgan Luttrell and the State Representative Greg Bonin with an MD. On the 3rd of September 2024, EMEA webinar on brain health is essential for smooth economic transitions towards socioeconomic sustainability, productivity, and well-being. On September 5th, 2024, the EMEA president, Professor Rim Ayadi, and advisor Harris Ayer participated at the first webinar on EU Coordination Plan for Brain. From September 11th to 12th, 2024, the Brain founder and CEO, Professor Alfred Kane-Jamshi, presented the Yaoundé Declaration at the first Nature Conference held on the African continent, The Future of Dementia. On September 18th, 2024, the Brain co-founder and CEO, Professor Alfred Kane-Jamshi, presented the Yaoundé Declaration at the United States General Assembly Science Summit on Brain Days. That was actually during the period of September 18th to 20th. On the 1st of October 2024, the Yaoundé Declaration was discussed with the Cameroonian ambassador to the UN office in New York. And on October 14th, 2024, the permanent representative of the Cameroonian government in the United Nations received in audience in New York the Brain founder and CEO to discuss strategies on incorporating the Yaoundé Declaration into implementation, instruments of the UN's Pact for the Future. 3 days after that, October 17th, 2024, the European Brain Council invited to address the European Parliament Public Health Committee in Brussels by Professor Claudio Bassetti. The Vice President addressed the Committee on Neurological Health and the increased momentum to address brain health and brain capital as a priority. During this address, he declared, "This broader understanding of the crucial role played by the brain as the powerhouse of our societies has been recently acknowledged by Cameroon, currently chairing the UN Nations General Assembly through its Yaoundé Declaration and calling for brain health in all policies." On December 5th to 6th, 2024, the Swiss Brain Health Plan second stakeholder meeting in Bern, during which we had a presentation and discussion of the Yaoundé Declaration within the framework of the Future Global Brain Alliance. In the same December 2024, the Lancet Neurology editorial notes that the Yaoundé Declaration as the key in policy advancement in 2024. In January 2025, that's from the 20th to the 24th, we had a presentation and discussion of the Yaoundé Declaration at the World Economic Forum, the Brain House event in Davos, Switzerland. It was highlighted at the Brain House event during the World Economic Forum in Davos and on the building of the Yaoundé Declaration, an actionable strategy involving the launching of the Davos Alzheimer's Collaborative Africa Task Force on Brain Health will constitute a major milestone on this roadmap. In the same January, that's January 28th, 2025 still, we had a presentation and discussion at the G7 preparatory workshop in London, Ontario, Canada. This workshop led to the publication of the Brain Advantage for a Thriving Economy, a global call to action, and its accompanying concept note by the Canadian Science Policy Centre, which builds on cities, the Yaoundé Declaration. On March 2025, that's March 18th, that's a few days from today, Brain has been invited by the European Brain Council to present a keynote address on the Yaoundé Declaration during the Brain Awareness Week at the European Parliamentary meeting in Brussels, focused on the EU thematic network
towards EU coordination plan for the brain. What are some of the expected impacts? As nations, regions, and global communities progressively buy into the call in this declaration and begin to formulate and implement proposed policies, we expect an increased awareness of strategic importance on brain health, brain capital in shaping future economies. This will result in programs and projects at various levels that focus more on promoting brain health, thus building brain capital, rather than the current focus on simply fighting brain disease in the health sector only. Furthermore, this paradigm shift is expected to reflect in the investment strategies and practices of national, regional, global agencies and institutions with more innovative and collaborative mechanisms, leading to a more national and equitable development and deployment of technical innovations that will guarantee sustainable development for all. As conclusion, Africa is the world's second largest continent and is home to 1.5 billion people, accounting for nearly 20% of the global population, the majority being young in this continent. It also hosts a rich panoply of social, cultural, geopolitical diversity across its 5 geopolitical zones, covering 54 countries. It is the most genetically, culturally, and linguistically diverse region on the planet. These factors make Africa the most suitable to lead the brain economy and to export methodologies, best practices, and new workforce models to the rest of the world. We have outlined clear calls to scale up the coordination, skills, tools, leadership needed to drive this new global economic transformation. We must rapidly transition from brain unhealthy economy to a brain healthy economy in order to unlock greater well-being, productivity, and creativity. This transition, therefore, means investing in the brain, in brain capital of all nations. Thank you. All right. After having said this, we will move to another phase of our program, during which we will be handing over some certificates on prizes to some people who stood out during the abstract and poster presentation. There are 3 who were selected as top 3 for amongst these abstracts which were presented and posters which were presented earlier on today. These certificates will be handed over to the participants by His Excellency, the Minister of State, Minister of Higher Education, represented here by the Secretary General of that ministry. I would therefore like to invite the different participants, and the first on my list is Dr. Nantia Stella. Can we put our hands together for her? Just to say that the first is not in order, but they were best 3. So whatever name is called, just know that you were amongst best 3. You may either have been second or third or first, but you are amongst the best 3. So I would like to invite, okay. Then the next participant or the next person to receive this is, we have Dr. Ayuk Constance Agbo. Is she around? Can we put a hand together for her, Doctor? While Dr. Constance makes her way, I'll be calling them for the last. We have Karim Widat Choroput. Where is he? Okay. So we'll invite His Excellency represented here to help us hand over the certificates. It's inside the envelope. Maybe I might just highlight. That's not. I would like to say that all they have is not just a certificate, as some would think. There is a cash prize attached to these prizes. Thank you.
Thank you very much to the Secretary General of BRAIN. At BRAIN, we like to promote talent and promote the youth. That's why I also can stand here, because our leader and executive director believes in promoting young people. So congratulations to all the presenters who had prizes today. We would invite the choir of the Faculty of Medicine to give us the national anthem. We would all rise as we sing the national anthem. And immediately after that, we would receive Professor Alfred Njamshi on this podium for the conference highlights and recommendations. And after him, we'll be hearing from His Excellency, the Minister of State, the Minister of Higher Education, here represented by the Secretary General. Thank you very much. Choir, please.
Au Cameroun, berceau de nos ancêtres, pas debout et jaloux de ta liberté. Comme un soleil, ton drapeau, qui doit être un symbole à nom de foi et d'unité. Que tous tes enfants du nord au sud, de l'est à l'ouest, soient tout amour. De servir que ce soit leur seul but, pour remplir leur devoir toujours. Chère patrie, tes chéris, tu es
Thank you to the choir of the Faculty of Medicine and Biomedical Sciences of the University of Yaoundé 1. And now we'll receive the conference highlights from Professor Alfred K. Njamshi, Founder, Executive Director of Brain Research Africa Initiative. Thank you, Prof.
Your Excellency, the Minister of Higher Education, Minister of State, Chancellor of Academic Orders, here represented by the Secretary General of the Ministry of Higher Education, Professor Wilfred Kapsa, colleagues from STAG, the representative of Alzheimer's Association, my brother from Bangui, Professor Pascal Mbeleso, Dr. Sakari from Jamina, Chad, dear colleagues, dear residents, dear students, dear representatives of associations, of senior people and people living with Alzheimer's disease and related dementias, ladies and gentlemen, it's a singular pleasure for me to summarize the highlights of the Alzheimer's Association International Conference Neuroscience Next 2025 Cameroon Hub as a response to recommendation number 6 of the first African High-Level Science Summit, coupled with the activities of the Brain Week that were supposed to end in 2024. This program was a 4-day program that started yesterday with a committee meeting, the steering committee meeting of the funded program that you have heard about, Build FSA, Building Unique Infrastructure for Large-Scale Research, Dementia Research in French-speaking Africa. That important and very successful meeting took place at the Brain Head Office in Obobogo in Yaoundé. This morning, this hall was filled by all these participants, and we started after paying honor to the flag of our nation. Professor Bisek and Cecile, Director of Health Operations Research, gave us introductory remarks reminding us of our July and August meeting that led to this one in collaboration with the Alzheimer's Association, University of South Texas, and the University of Yaoundé 1. Those opening remarks insisted on the need for an integrated, transdisciplinary, multi-sectoral action plan involving mental health, brain health, dementia, and other NCDs. That was followed by the presentation by Professor Jose Cavazos, Associate Dean at the University of Texas Health, USA, member of STAG, who led us through a video to understand how dementia care is carried out in their institution, and we have a lot to learn from the experience of that rich institution. The second articulation was a keynote presentation on building infrastructure for dementia research, care, and policy, a roadmap for Cameroon and French-speaking Africa by your servant speaking. Drawing from examples in our nation, we tried to insist on the need for building a brain health national program that will focus on young people, on early screening, and taking into consideration the emerging risk factors, mostly infectious and parasitic, from the research work that has been done.
The importance of research was stressed, and how research will inform policy, and research will inform training, and finally lead to these policy programs. This session was followed by a session by young neurologists and experts from various disciplines, including cardiology, geriatrics, imaging, health strategy, each bringing their specific perspective on the need for dementia risk reduction, research and care in Cameroon and in French-speaking sub-Saharan Africa. And this very interesting and informative session ended with a panel discussion that brought our colleagues from Central Africa and Chad together with experts from Cameroon to discuss how these principles could be translated into action. The interesting and good news was that it was seen that given the alignment with the Yaoundé Declaration used as a diplomatic instrument, it will be easier for the governments of Chad and Central African Republic working together with Cameroon to encourage them to build these health plans or brain health plans. And the last presentation for that morning was from Professor Crystal Glover, who is the editor-in-chief of Alzheimer's Dementia Journal, the newest of the series of Alzheimer's disease journals, who invited the audience to seize the opportunity to publish their research in this journal. And the great good news was that Africa, Cameroon, and Africa will have automatic waiver of the publication fees, which are usually a problem. And we can see how the Alzheimer's Association has us, I would say, not at heart, but at brain. Then we had coffee break and networking, and after that, people were able to visit the posters, and the poster presenters were able to present their work, and we have seen the work rewarded at the highest level of our Ministry of Education by His Excellency the Minister himself, represented here. Then we had the live session of the Alzheimer's Association International Conference. As you heard before, there were 12 hubs in the world, and we went live for 1 hour during that time from 1 to 2, and during that time we had the plenary session keynote from Professor Augustin Ruiz, who insisted on the importance of genetic research information in building precision medicine. And we learned that Africa has a place even in that. This was followed right after that by the lightning presentation rounds, where we had 4 researchers present their work in 4 minutes. And we had 3 presenters, 2 presenters from Cameroon, 1 from Chad, and 1 online from the Democratic Republic of Congo. It would please the Minister of Higher Education, Minister of State, Chancellor of Academic Orders, to know that apart from our colleague from Chad, the presenters at this lightning session were all trained, including our colleague from DR Congo, were all trained in the University of Yaoundé 1 Faculty of Medicine. That ended the session, and we can return from this morning session that the presentations described the problem of Alzheimer's dementia, Alzheimer's disease and related dementias as a serious problem. In the African context, we are not yet prepared, but we have a young and vibrant population, and we have already put in place, like the AI bond that was presented, and many other collaborations. The Build FSA research project that is soon going to start in 3 countries in sub-Saharan Africa, French-speaking Africa, and we have the political will to support, so we do not have to fail. the Director of Operations of Health took recommendations to the Ministry of Health, and we know that the Secretary General representing the Minister of State, Minister of Higher Education, we plead with you to take our deep gratitude for all the support that the Minister of State, Minister of Higher Education has been playing in this country to promote neuroscience and brain health, and in this continent, and even globally, because we know that when we talk about the Yaoundé Declaration, he was the architect behind it and is the one that convinced the government to be able to buy in, and we deeply appreciate that. And we plead with the Secretary General to transmit our deep appreciation, and through him to transmit our appreciation to the head of state, President of the Republic of Cameroon. Thank you very much for your kind attention.
Thank you very much, Prof. We will now receive the closing speech and remarks from His Excellency, the Minister of State, Minister of Higher Education, here represented by the Secretary General.
The founder, Brain Research Africa Initiative, Professor Alfred Njamshi, officials of the Faculty of Medicine and Biomedical Sciences of the University of Yaoundé 1, Professor José Cavazos, Associate Dean, and Augustin Ruiz, both from San Antonio, USA, delegates from the United States of America, Switzerland, Chad, Central African Republic, I heard Bangui, the Democratic Republic of Congo, distinguished members of the High Table in their respective grades and titles. I'm sorry I couldn't mention everyone present at the High Table, but you are all duly recognized. Dear professors, associate professors, senior lecturers, lecturers, assistant lecturers, residents, dear medical students, representatives of dementia patients associations and associations of senior citizens, dear choristers, distinguished invitees, ladies and gentlemen. I'll begin by submitting the apologies of the Minister of State, Minister of Higher Education, Professor Jacques Famudongo, to this important audience for not being able to make it here at this ceremony this afternoon. A few minutes ago, he called me to his office and asked me, what is this all about? And I told him this was a closing ceremony of what the Prime Minister started on the instructions of the head of state last week. And he asked me if Professor Njamshi could not preside over the ceremony of the Dean. I said, Your Excellency, you started it, you have to finish it. And he told me, since I'm busy, you do the job on my behalf, and that's the reason why I am here today. I want to thank him for giving me the opportunity to wear his shoes for a few minutes. I also want to express the gratitude to him for having given me this opportunity. Distinguished personalities, it is my singular pleasure and an honor to preside over this ceremony on behalf of the Minister of State, Minister of Higher Education, which is a follow-up of the first high-level African Science Summit on the brain economy, brain health, and brain capital, which took place last year, August 22, in this very hall of the prestigious conference center, and that was effectively presided over by the Prime Minister, Head of Government, His Excellency Dr. Chief Dr. Joseph Diangute, on the instructions of the President of the Republic, Head of State, His Excellency Paul Biya. He was acting as the Head of State's personal representative. Professor Njamshi, a few minutes ago, you were talking about the political will. If the Head of State decided to patronize this event last year and instructed the Prime Minister to preside over the ceremony on his behalf, there is no doubt that you have the support of the entire system. And it all depends on you what dimensions you want to take. The government is behind you, the Minister of State is behind you, and will submit whenever it becomes necessary whatever demands you have for the system. The historic summit, that historic summit, came out with 7 major recommendations, in addition to the Yaoundé Declaration, whose movement we have all listened to a few minutes ago. The 6th recommendation was for BRAIN to envisage capacity building programs in brain capital to promote brain health and brain economy for Africa, and work with the Ministry of Higher Education for the promotion of neuroscience education, training, and brain health research for development in our dear and beloved country, Cameroon. It is in response to this recommendation that BRAIN has partnered with the Alzheimer's Association, the South African Texas Alzheimer's Disease Research Center, to organize this Alzheimer's Association International Conference, Neuroscience Next, for the first time in Cameroon and in the SIAC sub-region. We all understand that Cameroon is one of the 12 hubs around the world that are hosting this international event during the course of this week. The theme of the Alzheimer's Association International Conference, Neuroscience Next in Cameroon, is, I quote, "The future of Alzheimer's disease and related dementia research in French-speaking sub-Saharan Africa." In Cameroon, the Alzheimer's Association International Conference Neuroscience Next is coupled with the annual Brain Week in Cameroon and Africa, generally celebrated under the high patronage, usually of the Prime Minister, head of government. It is on this note that on behalf of the Minister of State, Minister of Higher Education, I cordially welcome all of you to this academic, professional, scientific, and capacity building event taking place in this beautiful city of Yaoundé, the city which is built on 7 hills. It is true, we are all here for science, and you have been sharing your works and experiences with one another, building, networking, and building connections between research teams as the more than 8 billion neurons of the brain connect one another to make up the amazing organ that makes us who we are. That is the brain. I'll also encourage especially our friends from out of Cameroon to take some time off their busy schedule for sightseeing and enjoy not only the sights and sounds, but also the food, flora, and fauna of our country in its rich diversity, often referred to as Africa in miniature. And for those who don't know, Cameroon is also referred to as the continent. We are told by brain health experts that good nutrition and sleep, physical activity and good sight, and hearing beautiful sceneries, good music are amongst those things that promote brain health and prevent degenerative disease, such as Alzheimer's, dementia. This is that reason I want to take a second to express my sincere gratitude to the choral group for being part of this event. I can see that your brains are cool because of the beautiful voices we've been listening to. You've been listening to since this event started. Thank you so much for being present, and thank you for demonstrating that in the Faculty of Medicine, you also train not just the brain, you also train the heart. So I want to encourage all our visitors coming from outside to please take time and enjoy everything about Cameroon. Everything about Africa, everything about the world is in Cameroon. We just listened a few minutes ago to the sad story from our sister, Ms. Monique Chiapi. I think that creates a challenge for you, Professor Njamshi, and your entire team. 2 weeks ago, I was in the University of Buea on the instructions of the Minister of State, Minister of Higher Education, to inaugurate the Drug Discovery Center, sponsored by the Bill and Melinda Gates Foundation, to the tune of $1 million. The center has been constructed, the center has been furnished, it is already operational. And their base for the moment is plant drugs. I think it's your challenge you have to carry to take your research beyond research for doing research, beyond for discovering, to take it to the level of finding cure for these diseases. It is very important, and I think that's a big challenge we have to take. The story we just heard about today, that is a single story, but who knows how many of those situations are taking place every day all over the world, and no one is there to tell the story as Madame Monique just told us a few minutes ago. I want to congratulate the champion of this exercise, Professor Njamshi. Thank you for the sacrifice. Thank you for believing in yourself. Thank you for believing in the system. And thank you for all the challenge you are carrying every day to ensure that your research and activities go smoothly. It's a wonderful sacrifice you are making, and that tells how civic a Republican you are for our dear and beloved country, Cameroon. I want to thank the students here too who are present. As you open your brains, let your brains function fully, please. You have the opportunities. One of us just said it, Dr. Yembe told us he went to school free of charge. I want to believe you two are going to school free of charge. In Cameroon, we don't pay school fees. I believe we don't pay school fees. You know, tuition fee in Cameroon is 50,000, right? That's all you're paying. Believe you me, ask him how much you paid going to school in the US. I believe some of you don't want to travel ever to America. So thank you for being present, and thank you for encouraging our young students, and I want you to take the opportunity of the opportunity that the state has given you to ensure that you make yourselves useful medical doctors in the system. Please let your brains work in the interest of Cameroon and Cameroonians. Distinguées personnalités, mesdames et messieurs, le Cameroun est très honoré et fier d'abriter cette conférence internationale qui est la première du genre dans la zone CEMAC-SEAC, et ceci dans le cadre de la Semaine du cerveau du Cameroun et de l'Afrique, activité annuelle sous le haut patronage de M. le Premier ministre, chef du gouvernement. Le Cameroun et l'Afrique en général a une population majoritairement jeune, ça a déjà été réitéré, qui constitue notre capital cérébral pour le développement socio-économique. Mais, malheureusement, les cerveaux de la jeunesse africaine doivent faire face aux nombreux défis qui minent le monde actuellement. La drogue, des maladies infectieuses du cerveau, des attaques cérébrales liées surtout à l'hypertension artérielle, des traumatismes crâniens, l'influence négative des réseaux sociaux qui conduisent au manque de sommeil et manque de sommeil de bonne qualité et quantité. Les développements techniques tels que l'intelligence artificielle, certes, ont permis des avancées significatives dans nos vies, mais nous devons faire attention pour que l'être humain retienne son humanité, pour garantir le bien-être de tous et de notre planète. Les experts de la santé du cerveau nous apprennent que les femmes sont les plus touchées par le problème de démence, par exemple, que les hommes, malheureusement. Nous devons donc sensibiliser ces populations à risque pour le dépistage précoce afin de planifier les interventions de prévention ou de prise en charge par les services de santé appropriés. Nous avons aussi appris que les outils neuropsychologiques pour le dépistage et le diagnostic clinique de démence ou troubles cognitifs à tout âge doivent être adaptés et validés pour répondre aux spécificités de nos réalités socio-culturelles. Il y a donc du travail dans le secteur de recherche scientifique et de la formation universitaire des experts scientifiques, professionnels et de santé pour assurer la santé du cerveau de nos populations, des populations de l'Afrique, pour son développement et son épanouissement. Distinguées personnalités, mesdames et messieurs, tout en vous souhaitant à tous plein succès dans vos activités respectives, alors que nous tenons vers la fin de cette conférence internationale et pour la semaine du cerveau camerounais en Afrique, je voudrais vous assurer du soutien du gouvernement camerounais via monsieur le ministre d'État, ministre de l'Enseignement supérieur, pour la promotion de la santé du cerveau et en particulier la réduction du fardeau de la maladie d'Alzheimer et des démences apparentées au Cameroun et en Afrique, comme le préconise la déclaration de Yaoundé sur l'économie du cerveau, la santé du cerveau et le capital du cerveau. Before I close my intervention, I wish to sincerely once again thank the choral group for their beautiful and angelic voices. Thank you for the beautiful music. I want to thank the participants for your presence. For those who have traveled for once again, I wish you a wonderful stay in Yaoundé and hope that you find time next time not only to stay in Yaoundé, but visit other regions of the country so you can enjoy how diversified our country actually is. And you discover truly why Cameroon is referred to as the continent. I want to thank the students again to take advantage of this opportunity, explore science, make sure you exploit the experts who are here completely, and ensure that you take everything they came in with before they leave Cameroon. It is, ladies and gentlemen, on this positive note, that on behalf of the Minister of State, Minister of Higher Education, sincerely I declare closed the working sessions of the 2024 Cameroon and Africa Brain Week and the Alzheimer's Association International Conference, Neuroscience Next Cameroon Hub 2025. Long live university medical research, long live intergovernmental cooperation, long live international cooperation, long live our dear and beloved country, Cameroon, and its illustrious leader, His Excellency Paul Biya, President of the Republic, Head of State. Thank you for your very kind attention, and may God bless Cameroon.
Thank you very much, Your Excellency, for those kind remarks. We have come to the end of our program for today, and I'm going to give a snapshot of what tomorrow's agenda looks like. Tomorrow, we are at the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé 1, and as you've noticed today, we actually start on time at Brain, and we try as much as possible to stick to the agenda. We apologize that we've gone 45 minutes above our close time for today, but we hope that you had an excellent time of sharing and learning with us. Tomorrow at 9 a.m. at the Neuroscience Laboratory at the Faculty of Medicine and Biomedical Sciences, we're going to have a mentorship session with Professor Jose Cavazos, who is right here, Professor Augustin Ruiz, Dr. Crystal Glover, Professor Wilfred Bacham, Professor Bernard Fongang, Professor Paul Seke-Etet, and Professor Alfred Jamshi. So this is an open program for early career researchers and people who want to know how to develop themselves as researchers here in Cameroon. You will learn about the research cycle. You learn about how to design a research project, how to publish and disseminate findings. But as many people have observed, funding is sometimes hard to get, but there are tricks to navigate that, how to get funding. And then in the afternoon at 1 p.m. prompt, registration starts at 12. We will be at the Amphi 700 of the Faculty of Medicine and Biomedical Sciences of the University of Yaoundé 1 for a dementia symposium. And we would close at 4 p.m. With a meal, and that would be the end of our satellite activities for the AAIC Neuroscience Next Cameroon Hub. On Thursday, for brain research officers, we would be at the Brain Head Office for our coordination and planning meeting at 8 a.m. Thank you all very much. I'd invite the choir to give us one last piece. The Secretary General came back to you over and over and over again. So I want to make him smile before we go to the end of the session. So please, before we step out, I invite you to give one last piece. Thank you. While the choir is getting ready, we have the opportunity to take a group picture again, but this time with the Secretary General of the Ministry of Higher Education. And so we'll use the same format like earlier this afternoon. They would just stand up from their seats, and we would come to the front. Photographers get ready, and if there's an overflow, they would come on stage at the back. So please, protocol, thanks for helping with that. Thank you, choir.
Ilubanga
Thank you very much. We'll just ask the choir to join us at the back. Please just come on stage behind the Secretary General on the high table for the picture.